Started. Well, good morning, everybody, and welcome to the third hearing of the Committee's inquiry into fertility support and assisted reproductive treatment. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people who are joining us today. My name is Sarah Mitchell and I'm the chair of this committee. Can I ask everybody in the room to please turn their mobile phones to silent? Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants, and I encourage committee members and witnesses to be mindful of these procedures. So welcome to our first panel of witnesses, and thank you very much for making the time to give evidence with us today. I'm just going to ask for each witness, starting from Mrs. Crossland, to state your name, your position, title, but name's probably fine in this instance as you're appearing as individuals, and then swear either the oath or the affirmation that you have there. So I'll start with Mrs. Crossland.
Hi, my name's Rebecca Crosland. I'll be taking the affirmation. So I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
My name's Mary Van Ryck. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Good morning, my name's Karina McShane. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Hi, I'm Leah Appleby. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. There's an opportunity for each of you to make a short opening statement if you would like to. So I might again start with Ms. Crosland if you want to.
Yes, yeah, yep. I prepared something. Thank you for the opportunity to talk about my lived experience with secondary infertility. I would also like to acknowledge the families that have struggled and are struggling with their fertility journeys. I think it is crucial to talk to families that have experienced pregnancy loss to create awareness around fertility journeys, as it can be an incredibly lonely experience. In summary, from my submission, my husband and I had our first daughter in 2020, and when we decided to expand our family in 2022, we had a miscarriage followed by a missed miscarriage. During our second loss, the services provided at the local hospital left us more than disappointed and led us to seek private care. If I had my time again, I would have gone privately straight away, although many families would not be in this position. When I complained to the hospital, the Healthcare Complaints Commission and the local MP, I was told procedures had been followed correctly and there was a lack of funding even though the hospital was brand new at the time. We were lucky enough to have our second daughter in 2024, our double rainbow baby. With that said, pregnancy after loss comes with its own challenges. I believe services such as early pregnancy clinics that are dealing with families suffering pregnancy loss absolutely need more funding for clinic and theatre time. The fact that different hospital clinics have different clinic and theatre limitations seems grossly unfair. We don't only miscarry on weekdays, and my postcode should not determine how I miscarry. Thank you.
Thank you. Ms. Van Ryck.
My name's Mary Van Ryck, and over almost a decade I had 10 pregnancies, 2 of which resulted in my daughters, who are now 7 and 3. My recommendation to the inquiry is to seek ways to support parents in accessing the treatment of their choosing and ensure that pathways to financial support with flexibility built in are accessible to all. I was supported by my family and friends who lent me money for and helped me advocate for surgery to remove my septum, Chinese medicine and acupuncture to regulate my cycle, and counsellors to hold me through the years. Despite the support and advocacy I received from family and friends, it was still a time of extreme sadness and isolation, and my heart breaks for others who experience multiple miscarriages without those supports. The least we can do for those with the courage to keep trying is provide choice and some financial supports that are flexible, and this is what I ask the inquiry to consider.
Thank you. Ms. McShane?
Thank you, Chair and honourable members of the committee. I'm a mother of 2, soon to be 3 children thanks to IVF. My journey to parenthood has been complex. Although eligible for public IVF, my husband and I had to seek private care due to the lack of available sperm donors in the public system when we began. Since then, our experience has included interstate IVF with an anonymous sperm donor, the stillbirth of our son Raphael at full term, and pregnancy after loss care. Today, I would like to make 4 recommendations on these matters. Firstly, I urge the New South Wales Government to work with the states and territories towards a nationally consistent approach to fertility laws. The current state-based system creates unnecessary emotional, financial and logistical burdens for families already navigating IVF. For example, despite completing mandatory counselling in New South Wales to access a sperm donor, we ended up choosing a Victorian donor, and so we're required to repeat the same counselling remotely in that state due to a lack of cross-recognition. Inconsistent regulations around donor limits also restrict access. I'd like to reiterate what other witnesses in previous hearings have said, that a nationally consistent 10-family limit would help improve access whilst maintaining safeguards, as compared to the current New South Wales limit of 5. We've also experienced changing and unclear rules. When our embryos were created, we were advised that once we had had a live birth, the remaining frozen embryos could be transferred back to New South Wales. When Raphael was stillborn at almost 41 weeks gestation, it meant we again had to travel to Melbourne for treatment when we were ready. Although our second child was thankfully born alive, we were advised earlier this year that the rules had changed. Because the donor had reached his 5-family limit, we had to continue our treatment in Victoria. With IVF procedures often confirmed at very short notice, coordinating interstate travel, work and care for our toddler is, for us, a significant and ongoing challenge. Secondly, I encourage the committee to work with employers across the state to better support people undergoing fertility treatment through appropriate leave entitlements. Fertility treatment should not rely on discretionary workplace policies or require staff to utilise their valuable personal or sick leave. A legislated minimum entitlement to paid leave would provide much needed consistency and support. Thirdly, per the Safer Baby Bundle produced by the Stillbirth Centre of Research Excellence, the prospective risk for stillbirth at full term is higher for pregnancies conceived via ART than natural conception. I urge the committee to actively promote the Safer Baby Bundle. I've heard of many families who have been told by their obstetricians or midwives that an IVF pregnancy does not carry any additional risk, which is incorrect. There is significant misinformation in the community on this topic, and I fear that families are not being adequately informed of the risks by their care providers in pregnancy. And finally, I urge the committee to consider greater investment into pregnancy and infant loss support services. Bereavement midwifery care should be standard at hospitals across the state. When our son died, the bereavement midwives at our local hospital propped us up, managing my physical care, the necessary death admin, and support in a subsequent pregnancy. I understand that these services are few and far between, even in large teaching hospitals, and I implore the committee to invest in this critical resource. Access to good bereavement care should not depend on your postcode. Thank you.
Thank you. Ms Appleby.
Thank you for this opportunity. I'd like to acknowledge everybody behind the scenes who have been campaigning for change. I am here because of my losses, and because those losses revealed, one by one, how profoundly this system needs to change. But my story doesn't start with pregnancy loss. It began at 31 when I was told that I was entering into early menopause and to freeze my eggs if I ever wanted children. So if the goal of this inquiry is to make recommendations and to introduce change, I would like to put forward these 5. First, medically recommended egg freezing must be covered by private health insurance. When a fertility specialist tells a woman she should preserve her eggs for a medical reason, that is a clinical recommendation, not a lifestyle choice. Insurance companies currently say, sorry, but you are on your own. That must change. Second, education. It is so important. All I was taught at school was how not to get pregnant. and that I will get a period every month. If cycle literacy, hormone education, and understanding of what diminished ovarian reserve means, the shortening cycle could be worth investigating. There may have been different intervention and a different outcome for me. On miscarriage specifically, I was 37 years old when I found out what a missed miscarriage was, because I was going through one. Last week, a friend older than I, who was also experiencing one, had to Google the term when I used it. That is not a gap in two women's knowledge. That is a systemic failure. I spoke to teachers across public, private, Catholic and Christian schools in preparation for today. The consensus is that there isn't enough being taught. The 2027 syllabus mentions fertility and grief, but hormonal health is still absent by name. At a minimum, there should be a dedicated module in the About Life Ready course that every student must complete before leaving school. Third, recurrent pregnancy loss must trigger investigation after 2 losses, not 3. Women should not have to lose a 3rd child before the system asks why. Fourth, miscarriage leave must urgently be extended, and funded psychological support must come with it. Australia's 2-day entitlement is one of the weakest in the developed world. Casual workers receive nothing and partners are invisible. Northern Ireland, just last month, said that they will increase it to 2 weeks paid leave. India has 6 weeks. And it is important to note that this should be bereavement leave, not sick leave, because when you lose a baby, you are not sick. You are shattered into 1,000 pieces. You need time to grieve. But time alone is not enough. 1 in 3 women develop PTSD following early pregnancy loss. That support is currently delivered by underfunded charities. And fifth and final, the economic burden and impact of the fertility journey must be formally recognised and addressed. A fertility journey is not just a specialist and a Medicare rebate. It is acupuncture, naturopathy, supplements costing hundreds of dollars a month, specific diets, counselling and monitoring appointments that pull you out of work week after week. I can't tell you the number of practitioners I have subscribed to online searching for answers as to why I keep miscarrying and how I can stop it. Women are spending tens of thousands of dollars, sometimes rating their superannuation, in an unregulated, unsubsidised space with no clinical coordination and no government guidance. We need an integrated care model where a GP, fertility specialist, counsellor and complementary practitioners work together with a recognised, partially subsidised framework, and private health insurers need to be at this table. Thank you.
Thank you all. So the committee's resolved that we'll just have sort of free-flowing questions from members, and I should note one of our members, Emily Savali, is online, so if she has questions for you, she should pop up on your screen. There she is, there we go. So I might just start and then I'll hand over to colleagues. I just wanted to firstly say to all of you, thank you so much for coming and sharing so openly the stories of loss, and we are so sorry for all of the losses that each and every one of you have been through. You might know I've got some lived experience with pregnancy loss as well, so a lot of what you're saying certainly resonates with me personally too, and it's not something that the committee takes for granted, your openness and willingness to be here. So I think I speak on behalf of everybody. I just wanted to say that to start. One of the many issues obviously that we're looking at through this committee does go to the financial support that is available for people who are going through a fertility journey in lots of different ways. And I wondered sort of from each of you, not wanting to make you feel uncomfortable sort of sharing, but there's obviously a lot of costs, whether it's going through IVF, whether it's time you need to have off if you're dealing with several miscarriages or fertility testing. What sort of financial supports for you in your circumstances do you think would have made the most difference, I guess? And all of you happy to answer, whoever feels comfortable. So.
Well, firstly, my egg freezing, that was all privately paid for.
Mm-hmm.
I would have loved some sort of help along with that.
Yeah.
When I miscarried 3 times, paid leave, at least more than 2 days would have been appreciated. But I guess I haven't started IVF. I haven't gone down that IVF route yet. I'm I can't keep a pregnancy. So yeah, I think I'll leave the other questions for you guys.
Yeah.
Yeah, I think the biggest challenge for us is that we were eligible for publicly funded IVF and then we couldn't do it. So I'd say, in addition to better support from our health insurer, paid leave for sure would be a big one. And obviously for us, our story involved interstate travel, so that brought a significant cost. I don't know if that's something that I don't know if that directly answers your question.
No, it does. Yeah, no, that's helpful. Yeah.
That was the biggest cost for us, really.
Yeah.
For me, when I was diagnosed with a septate uterus, there was funding through a public hospital to have it removed. However, the hospital where I was presenting, which was Wollongong, didn't have equipment that they said it wasn't the most up-to-date equipment, and the recommendation for the surgeon was that if I wanted to have multiple pregnancies, I should use equipment that is the most up-to-date. So that's why I had to then go into a private hospital, because they had that medical equipment. The surgeon at the time asked that hospital if they would lend the public hospital the equipment, even to try and get it done through Medicare, but that hospital refused. So I did end up having to borrow money off my family to pay for that and then repay that loan. So that was really hard. And I think because of the extensive time it took me to complete my journey around my pregnancies, it was almost a decade. And so across that, I sensibly chose to see a counsellor that whole time. I did have initial funding around my first experiences with miscarriages with seeing a specialist counsellor. However, that funding was only for a limited number of sessions. I think it was 6 sessions. And when you're looking at 8 years of infertility counselling, that doesn't really add up. I did get a mental health plan to see other counsellors. However, there was always a significant gap. So I was paying for mental health support across 8 years, which does add up to quite a significant amount.
Yeah.
I agree with paid leave. I took 2 weeks at both times that I miscarried. With our second loss, we had to pay privately to have a D&C done, so that came at a cost. I also engaged a psychologist after our losses for a number of years. Yeah, I think that's sort of everything for us. We haven't gone through IVF or anything like that either.
So I think, it's probably a bit of a combination of sort of the immediate cost depending on your circumstances, but also maybe some of the longer term things that might need to be in place. One of the submissions from some witnesses we're hearing with later today have talked about trying to embed more in the public health system specific people who have experience with bereavement, pregnancy loss, so that, women and families and people going through this journey, whether it's their first or, their multiple losses, they have someone there who actually is trained and knows what they're doing, and that's staff training more broadly. Is that something that each of you in your experience, there's a lot of nodding for the benefit of hindsight, if you wanted to talk to that, maybe what would have been helpful for you in that sort of emotional sense throughout the journeys?
I'll go first if that's okay. When my son passed away, I had given birth in a very large teaching hospital here in Sydney, and we were told by the hospital that I could only access mental health support through the hospital if I'd had a miscarriage or if I was undergoing cancer treatment. And those were the only 2 instances in which we could get any kind of support. So we had to rely on a not-for-profit, in particular Bears of Hope, who provide free counselling for anyone that's undergone pregnancy or baby loss forever. There's no cap on that offering, which is incredible. But I don't think it should be up to third-party organisations to have to provide those services.
Ms. McShane, can I just ask how long ago that was?
My son passed away in January 2024.
Okay, so very recently, really.
Yes.
Thank you.
Did anyone else want to sort of comment about, if you were in our position and we could make recommendations to government about what should be in each hospital or what should change for that experience for people going through loss, what would you like to see?
I think definitely a specialist worker and a specialist space as well.
Yeah.
Often my conversations were with someone who was an expert in ongoing pregnancies, and I was held in spaces with other women who had ongoing pregnancies when I was experiencing a miscarriage. So if I wanted to have conversations about what was happening with me, I had to prepare myself to enter that kind of a space and to speak to someone who I knew their next appointment was going to be with someone with an ongoing pregnancy, and that was very hard for me to have a separation between pregnancies and bereavement of pregnancies. I think is really important, and to reflect that in the roles that people in the hospital have. If someone is a specialist there, that does make a huge difference, I think. And yeah, that's what I would say.
I think public hospitals could offer, more support. We, at the early pregnancy clinic, were given a bag from Bears of Hope, and here are some resources, and then sort of sent on our way. There wasn't any follow-up from memory. It was, we were sort of just, sorry that happened, and here's some resources, off you go.
Can I just add, I think what you were saying is really important as well, that Leo was sharing, that at the moment it has to be 3 miscarriages to qualify for that support as well. And I just really feel like, when you have that first experience, you don't know if that is going to be a one-off experience or if that is going to be an ongoing experience. And you also don't know how much that initial miscarriage is going to impact someone. It may impact someone just as much as a third loss may. And if you can have that conversation earlier and you can understand those pathways of support earlier, I think that if you are going on a journey like me where you are going to be having recurrent miscarriages, the earlier that you can engage with those supports, and through a public hospital that will be continuing to support you through those ongoing miscarriages, makes you feel more supported across your journey, and it recognises that it is an accumulated impact that you are experiencing. Otherwise, I think medical centres are often quite reactive and responsive to single incidents. But it's more like, it would be great to have a hospital that is more like, with your GP, where they understand the ongoing nature of your condition. If there were specialists that, had their own case files and their own, connections with patients, they would know. I was very lucky. There was one woman there who, when I would come back, would be like, I'm so sorry to see you again. And just having her recognise that I had been there before was a really big thing for me. Not, it was very hurtful when I would have to see someone else and they would be like, and what are you here for? And you'd have that inevitable, so what is happening with you? Like once I called up and an admin person was like, I can't refer you to a specialist until I know what's wrong with you, because I don't know which specialist to provide. And I cried so much at that, because I was like, I don't know what's wrong with me. That's why I've come to this hospital, is to try and find that out. But to have a specialist at the hospital who has ongoing relationships with people who are having ongoing miscarriages or experiences with bereavement around pregnancy, I think would just be so comforting at real moments of crisis, or real moments of deep sadness, to be seen with your history and your other babies. I guess it's someone that remembers the other babies you've lost before in that current moment, and being able to acknowledge those other babies is huge.
And I think there's certainly scope. I mean, I know in some overseas, New York, I have the chance to visit like rainbow clinics, where basically people know and go into that space knowing they've been through loss, and all the staff and clinicians know, and it's just a much nicer environment for people. And it might be something that that should be adopted here.
Exactly. They know that there's like phrases or sentences that they will know to omit. Like, they will know not to say or do certain things that you would do with an initial loss, and just to be cautious around some of those things that may trigger you, or and to have separation for those people from the pregnancy ward. Again, I would just say, to not have to sit in a waiting room with other pregnant women when you're going through a loss is a huge thing.
Can I just add to your spaces in particular? I had to give birth to my baby who had passed away, and at the same time the room next to me was a woman giving birth to a live baby.
Yeah.
That shouldn't happen. There
Yeah.
should be separate spaces for these things.
Mm.
You know, had feet in stirrups, and you know, it's traumatic. And having to sit the next morning waiting to be discharged, listening again to more women giving birth to live babies. As you say, there should be a centre where we can go and do these things. And just being in the same space as women who are smiling and they're so excited for their pregnancies, and you know that you're not going to go home with a baby.
If I can add to that, actually, I think a recognition that this kind of grief never goes away as well is really important. When my daughter was born, I had a similar experience where I wasn't in the ward with other women who had just given birth, but I was kind of being wheeled past another woman who had just given birth to a baby boy. And for me, that was extremely triggering. Even though I had just given birth to this beautiful, healthy, living girl, it will never leave me, the fact that my first child, my son, was stillborn. And I think not only having the continuity of care, but a recognition that grief doesn't end. It changes over time, for sure, but it never really ends, I think is really valuable as well.
Yeah. Thank you. I might hand to Dr. Connors.
Thanks, Chair, and thank you all so much for being here today. This is really valuable for the work that we're doing. I really appreciate it. I wanted to come back to Karina. You said something in your opening statement about the cross-jurisdictional issue, which really strikes me as low-hanging fruit for this committee to resolve. Can you explain in more detail exactly what had to be repeated and whether that was New South Wales or Victoria that was requiring that?
Yeah, absolutely, I can. So when we transferred to Victoria, the number one thing that we needed to repeat was the counselling sessions. We had already done 2, if not 3 counselling sessions with a New South Wales counsellor. I think they're about $300 a session from memory as well. And when we transferred to the Victorian clinic, we were told that we would need to repeat the sessions, because even though the New South Wales counsellor had exactly the same qualifications, they were registered in this state and not in Victoria. So we needed to have those conversations again. But that's kind of tip of the iceberg, really. When I think about our children being born and registered into a central authority of donor-conceived people, my daughter is registered in Victoria. She's not registered in New South Wales in that regard. And that seems really fraught to me for a number of reasons. So I agree, it seems like really low-hanging fruit from my perspective. And I think that we can only benefit from change in that regard.
Okay. And this issue where your daughter's part of a registry in Victoria, what impact has that had on you or on her?
So right now there isn't a direct impact, but I'm thinking about when she is older, because once she turns 18, she can apply to the kind of central registry. In Victoria, they're called VARTA, V-A-R-T-A. And she can ask for access about the sperm donor that we used. I'm not exactly sure off the top of my head what kind of information, but if she wants to, she can try to make contact with that donor. I guess the impact is that if she decides to continue to live in New South Wales, I mean, she does always have this connection with Victoria, but it seems kind of arbitrary to be governed just in that one particular state when she's been born in Sydney. She's lived her life here. We probably will live here for much longer. It doesn't make a whole lot of sense, and it seems like there's some risk involved there as well.
Thank you for explaining that. That's helpful. And I also wanted to follow up, Mary, you wrote in your written submission about your experience of some of the mental health support you'd received, and that wasn't necessarily culturally appropriate for you. And I'm interested in what you'd recommend, or what a better support would look like that was culturally safe.
Just the lower house is sitting, so bells will ring for them.
Okay.
If we don't run, you don't run. It's fine.
Okay, great. Yeah, look, for me, like, my background is that my dad's family is Sri Lankan, and also my dad is actually a queer sperm donor. So I actually come from a rainbow family. And just in accessing supports, because there was such narrowness in options for me, if I wanted to go through formal pathways, there wasn't really many options around what kind that support looked like, which meant that often when I was explaining my situation, I understand that it's very interesting for people to learn about a rainbow family that is, older like mine. Like, when Dad was doing it in the 80s, it was kind of, not so common. So people are always interested about it, and I understand that. But when I'm talking to a support worker, I don't want to feel like I'm an interesting story for them. I want us to focus on the fact that I've just lost a child. And, or, people will be interested in my Sri Lankan heritage, which they'll talk about wanting to go on holidays there, which I understand, and I value the interest in that country, but it's not what I'm talking about. And so I find that when I go to practitioners of colour or practitioners with lived queer experience, it's a very different experience for me, because I don't have to explain so much to them, and we can really get to the nub of the issue. However, when I go when I look for those options, there's just not enough around at the moment. And I guess it's around supporting funding identified positions for people with lived experience, that are people of colour or people who identify as queer, to give those, experiencing grief and loss the opportunity to talk to someone who is further along in their understanding of my experience and can pick up the conversation at an appropriate place, rather than me having to, explain about turkey basters back in the day, which is always a fun thing to talk about. But yeah, it often detracts from my experience, because it takes me out of the role of someone who is grieving into the role of someone who's educating, and that's that's not appropriate at those times.
Thank you. You've explained that really clearly. I could do this all day, but I'm happy to share time with my colleagues.
We'll go.
Just a quick question. I'm conscious of time. Ms. McShane, could you tell us more the Safer Baby Bundle, what that involves and what better education or better awareness of that would look like?
Yeah, absolutely. So the Safer Baby Bundle was produced by the Stillbirth Centre for Research Excellence. And essentially it's a resource to help lower the rates of stillbirth. Not all stillbirths are preventable, but some of them are. And so it's kind of an information source to give both pregnant people and clinicians some very practical ways of reducing the rates of stillbirth. So, for example, not smoking during pregnancy or sleeping on your back after 28 weeks. The particular piece that I'm really interested is how the Safer Baby Bundle identifies IVF conceived pregnancies as higher risk at full term. In my experience in engaging with my local hospital, I feel as though that knowledge is not consistent across midwives and obstetricians. I think some people know about it, but it does not appear, in my opinion, it does not appear to be kind of standard knowledge. And my concern, as I said in my opening statement, my concern is that care for pregnant people should not be based on what a clinician might happen to be up to date with, I suppose. That sounds a little bit cynical, but...
No, that's very useful. Does anybody else have a comment, similar experience or different experience in terms of education of clinicians and midwives and other hospitals?
Mine's sort of around more like pathology. Like I went to get a blood test to confirm the miscarriage. And she said to me, "Congratulations." And I was like, not a congratulations today. So like even it's much broader than just hospitals or obstetricians and things like that.
It flows down to sonographers.
Yes.
The person that told me my baby no longer had a heartbeat just went, "Yep, no heartbeat."
It's a very similar experience.
And I had a miscarriage diagnosed while I was having an internal ultrasound, which I can't tell you, I'll never recover from that moment. I'll never recover from it. One thing that I would say is that, you're right, it is broader than that. And I wonder if there is an opportunity for some kind of short course or education process to be made available to health professionals across the, in all the different facets where you come into contact with pregnant people or people who are experiencing miscarriage or bereavement, which could be around, trauma-informed care, specifically around those conversations, and as part of an education piece, I think it would be really valuable. Just, a short course, just saying, that assumptions can be really hurtful when you vocalise them.
Yeah.
Thank you.
Miss Hurst? And I'll go to, I don't know whether Miss Savale's got questions, but we'll go to Miss Hurst first and then we'll...
Great. Thank you,
online.
Chair, and thank you all so much for coming today to share your stories. We really appreciate it. I've got a specific question for Ms. Crosman, and I've read your submission, and what you went through in the hospital sounds really horrific, and thank you for sharing that. I just wanted to get an understanding from your experience what really needs to change within the current healthcare system so that women don't go through the same experience that you did. I know that you said in your opening statement that you were told that there was no problems there, but obviously your experience is very different to that. What really needs to change on that ground level to make sure that there is the proper support so that women can make a decision in the situation that you had? You were sort of given options, but at the same time everything was delayed and the information wasn't coming to you.
Yes, yeah, so thank you. The biggest thing that I realised, which I didn't, you never know until you're in that situation, was that there is a difference between hospital early pregnancy clinics and their access to clinic time and theatre time. So the hospital I went to was like a brand new hospital, but they only operated 3 days a week, 9 till 12. Whereas the hospital half an hour away, which I was not zoned for and could not attend unless it was an emergency, had clinic time from 9 till 5, Monday to Friday, and theatre time every day. So I was unable to access the treatment that I had chosen, which was a DNC, so we could have karyotype testing done on the baby. So we didn't have to wait till the third miscarriage, like I mentioned earlier, to see kind of what was happening. And yeah, they had said that there would have been a delay. So it was a week, nearly a week, that I knew that our baby had died and was unable to access treatment. And then, I think them sort of explaining that it did come down to zoning, seems ridiculous to me. I think everyone should be able to access services they want, and it is their body. I understand it would have been more expensive to facilitate, but you're already going through so much. If you have that's the one choice. We have no control over if we lose this baby or not, but we do have the choice in determining how we deliver that baby. So
exactly.
I think that, there's a lot of room for improvement there.
Yeah. I would just support what you're saying there, Rebecca, in that there is nothing that prepares you for the experience, for knowing that you are holding a child that has died within your body, and that you don't have the say over how long you sit with that. And I think when we talk about leave, that's something to consider. Like you said, you had to wait a week. I can't imagine having to go to work for a week while you know that you're holding a baby that has died. That is an incredibly difficult thing to have to choose to do. And it was the same with me with my DNCs, with my miscarriages as well. Having to have a discussion with someone about, we can probably fit you in next Friday or something like that, is a really difficult conversation, and it's going to be different for every woman. Some people might need to spend the time with that child. They might need that longer process or to talk about that extension, but it should be something that you're able to discuss with the hospital and make a choice on. It shouldn't be simply around scheduling. We know that hospital scheduling is hard, but when there are other options such as another another hospital in the area that can accommodate you, that should be considered as an option.
Yeah, no, it seems very obvious. Thank you.
Yeah. And just to add to that, I did ring around local obstetricians and gynecologists, but because I was not a patient of theirs, I could not be seen quickly. So they wanted an appointment to discuss and then to schedule the surgery. So I think when I made my complaints, because obviously something has to improve, they said, oh, well, it was a similar timeline for other obstetricians and gynecologists, but they had a different way of looking at things. So
it doesn't mean that the system's not broken.
No, but there's definitely room for improvement. Yeah.
Thank you. And I've just got one quick question for Ms. Appleby. You talk in your submission about insurance companies and that 12-month waiting period before people can access fertility support. Can you talk a little bit more about that and your situation or other situations where this is just not a practical situation and what needs to change?
Yeah, so I've always had private health, but with everyone that wants to get pregnant, you have to probably, increase your insurance, and you have to do 12 months on that cover before you can access that. But when I was, told I was going into early menopause, I wanted to have to freeze my eggs, and I was hoping to be covered by private health, but because I hadn't had that level of cover, I hadn't done 12 months, then I had to pay privately, and I didn't have time. I didn't have 12 months. My clinician was telling me to freeze them then and there. I did 3 rounds and I only got 4 eggs. So I don't have 12 months. I mean, that was when I was 31, 32, and I'm now 37. I'm still trying to fall pregnant. So some would argue maybe I do have time, but I was only dealing with the information that I had at that time, and I was being told, I was told I will never have natural children. So I didn't have 12 months to wait.
Yeah.
Thank you.
Thanks, Em. Ms. Val, Emily, online, I think, some questions?
Thanks, Chair. And apologies that I can't be there in the room with you. Thank you very much to all for your evidence and for making the time to appear today. It's been extremely valuable to hear from all of your perspectives. I wanted to ask, if I could, to start quite a specific question to Ms. McShane, and thank you for sharing the story and for telling us about Raphael as well. It's, it really adds to the insights that we're able to gain when we hear firsthand about people's experience. So I just wanted to acknowledge Raphael in my remarks. In terms of the support that you were able to receive post delivering Raphael, I think in your remarks you mentioned not being eligible for follow-up because you hadn't had a miscarriage or there was another classification. Could you just explain a bit more about that and why that was the case? That seems very strange to me.
Yeah, absolutely. And I have to start off by saying that the experience that we had with our hospital when I delivered Raphael in the days afterwards, it was incredibly positive overall. The bereavement midwives that supported us, the social worker that supported us in that time, we had a really, really positive experience, which sounds kind of funny to say because our child had just died. But honestly, and listening to both of your testimonies, the sense of control that we had in that time and the respect that was paid to us has made an enormous difference in our healing process. And I very confidently say that. So I have to start off by saying something positive. But yes, in terms of the psychological support in that time and then in the following months, we were told by the hospital that, and it's my local public hospital, a very large one, we were told that I could only access one of their on-staff counsellors if I'd had a miscarriage or if I was receiving cancer treatment. So they gave us referrals to private psychologists or to not-for-profit organisations. And I agree, it does sound very strange.
It's crazy.
Yeah. it also just seems like a, I suppose, you know, this is a service that has all of the information about, you know, the care that you received, your experience. So in terms of that continuity piece, and to sort of prevent you from having to retell it, because, you know, it's, you know, if there is a process involved with finding the right clinician to see for something like this. So perhaps that's something that the committee, would you think it, you know, if the committee could recommend looking at if we can suggest that that services include, and it seems wild that they wouldn't, but include stillbirth. If it doesn't fall into the neat categories of a miscarriage or a, you know, cancer treatment, at the very least, you know, that should be something that we're offering people.
Yes, I absolutely agree with that. I can kind of see how it happened. My suspicion is that it's based on demand, but it seems kind of cruel to be deliberately excluding particular groups of patients. I don't see why any person undergoing pregnancy or infant loss shouldn't be included in that kind of support service.
Yeah, thank you. It's again, it still hurts my brain somewhat. So, but thank you very much for clarifying. Again, I also wanted to ask, I think Rebecca, if I can, you mentioned in your opening statement secondary infertility. I believe that was you.
Yes. Yep.
Yeah. Sorry. It's a hard because I on screen. I can only see the four of you, but I just wanted. It's I think one of the first times that someone has mentioned that in the hearing. So I just wondered if you could share from your perspective whether there were any gaps in the care that you received or otherwise because of that, or because people weren't aware of what that was.
Sure. So my understanding, like, I had a successful pregnancy and then 2 unsuccessful pregnancies, followed by another successful pregnancy. And we weren't sure why I was miscarrying. There was no real reason. When we did get the karyotype testing, we did get some results for the second loss to explain that, which we wouldn't have if we went the public system route. But anyway, so it's, I forgot what the question was. I started talking.
Just around secondary infertility and people's, I suppose, lack of awareness as to what that is and how that impacts you.
Yeah, I don't know if there's any differences in secondary infertility impacts compared to infertility. I don't know.
Can I jump in, because I'm
Yes.
also going through this, and I think it's maybe stigmatized, maybe the social understanding. People, it's the comments being made like, oh well, at least you have one.
child. Yes.
At least you can get pregnant. But it feels like it's an internal battle as well. You know, is it a case of gratitude and being grateful for what you do have, versus feeling sorry for yourself that you can't fall pregnant and have the second one. So it's a daily internal battle as to what perspective do I have today? Am I grateful for what I do have versus my hope for what I might have in the future? And I guess from a person sitting on the other side of the fence who doesn't have the understanding, perhaps they might sort of say, at least you've got one. I can't even have one. And there's a lot of guilt around that, but there's also not enough education around how to deal with that, just from even your peers. My friends don't know, some of them don't know how to talk to me anymore, or how to support me. And that's not on them. That's just, I think, a lack of education and understanding across the board.
Definitely.
I think you explained that really well. Thank you.
And can I just say, I haven't heard the term secondary infertility, but that is actually what I experienced.
Yeah.
So actually someone who has lived that experience, and I have talked to so many specialists and counsellors, and I don't think anyone's literally ever said that term to me before, which is just really mind-boggling, because I have had 8 miscarriages, and I had, you know, and some of those happened after my first child was born, and the fact, I think it's just, as you say, just a real lack of education. And I think it's a lack of education as well, in that secondary infertility is often unexplained. It's so unknown.
Yeah.
I think, like when I was contacting the hospital and people were asking me what was wrong, that's, you know, people are always expecting you to have an answer. And I think education around the fact that it's not always helpful to seek an answer. Sometimes it's more helpful just to work out the best way you can support someone who is going through that journey, because you ultimately have no idea how that journey is going to end. You know, supporting people to sit in the unknown future is a really specific thing. And again, you know, an educational course around, you know, supporting the, you know, the trauma risks around supporting people who are facing that uncertainty. I think, you know, the hospital staff or medical practitioners, as you say, like from pathology to gynecologists, would be really helpful, because we are already fielding these kinds of questions from our friends, from our family, who are all well-meaning, and we can take that, we can understand that they won't have that knowledge because they haven't lived that experience. But when you are in a medical setting, what you are asking is for people to already have that knowledge, so you don't have to explain it to them, or, you know, they don't respond in a way where they are focusing on what is the answer, that they are just focusing on where are you at in your current journey and how can we support you.
If I can add to that, if not necessarily to have the knowledge, but at the very least to not make assumptions.
Yes. Assumptions.
One of the,
Exactly.
I've got a personal anecdote in mind. When my daughter was born, I spent a few days in hospital, and I was seeing a lactation consultant, and she was running little classes in her room. So I was in her room with about 5 other women who had just given birth in the last couple of days. And the lactation consultant hadn't read my notes at all, even though she was expecting me. And she asked me, "Is this your first child?" I said, "No." She said, "Did you breastfeed your first child?" I said, "No." And she said, "Well, why not?" In front of this group of, you know, brand new mums. And I then had to explain myself and say, well, actually, I didn't breastfeed him because he died. And, you know, I could see that she was absolutely mortified, but the assumption that had been made. And I know that, you know, not every pregnancy ends in loss, of course, but when it does, it is utterly, utterly devastating, and it completely changes your entire life. And so I think for health practitioners to question assumptions they are making when talking to people is really, really important.
Yes.
Thank you. I think Mr. Donnelly has a question.
Thank you. Through your chair, thank you all for coming along today. Thank you, first of all, for the submissions, which were all very insightful and profoundly, deeply emotional for obvious reasons, and the additional evidence you're providing today. I've got limited time, so there might be some questions that I'll put on what's called notice, because time's passing. So I just might start just with one question with Ms McShane, and if I've got time left, we'll go to others. Ms McShane, in your opening statement, you made a comment about, I think the phrase you used, misinformation in the community about the practice of IVF or ART. Sometimes the two terms are used interchangeably. I'm wondering, though, that with respect to the provider to you of IVF, ART, and I'm not asking you to declare what that company was, where it was located, or what have you, in terms of its name, unless you're willing to do so, and that's for you. I'm wondering, was your experience that you received from them clear and accurate information about what you were entering into? And the reason I ask is that there are arguments that are in the public domain that one of the big issues is concern about whether the IVF providers are being somewhat optimistic and overly positive in putting before the woman coming to obviously pay for service, the route being taken and the actual likely success of the outcome and related matters. And one of the things has been exercising my mind is that from those that have been for this experience with private providers, is that their experience that in fact they did receive clear, accurate information, or that they had some concern either at that point or after, looking back, that information perhaps is not as clear and accurate as it should have been.
Thank you. That's a really great question. I would say overall our experience has been really positive with our clinic. We are with one of the big national providers, and I feel as though they've done a very good job of managing our expectations from the outset. They were very, very cautious, I would say, particularly in giving us the statistics around pregnancy. I have been told by my specialist that each time we do an embryo transfer, it's only a 50-50 chance, which is true. And in actual fact, I mean, we are doing IVF because my husband is infertile. It turns out that I am actually quite fertile. I'm now having my third pregnancy in 3 years. So our experience has been positive in that regard. But I will say particularly in regards to the Safer Baby Bundle and the small but still prevalent risk or higher risk of stillbirth as associated with ART. We were not given that information by the clinic from the outset. But in thinking about how I might have received it by the clinic, you know, in the early days of having our IVF conversations and in starting the process, I don't necessarily think I would have taken it on board. I would think, and you know, we all have experience of this, I suppose. If you've gone through IVF, you are so focused on what's right in front of you that the end goal of getting to the end of a pregnancy seems very, very far away. I think there probably is an opportunity for the clinics to provide that information along the way once you are pregnant. But there is so much information to absorb when you are starting out IVF. I'm not necessarily sure that it would actually be that the stillbirth specific risk would actually be absorbed or received in those early days.
So is your evidence, if I'm understanding correctly, that only on the matter of stillbirth, which you've specifically referred to, that you were satisfied with the information that was provided to you with respect to all the elements, I mean, that may not have been at the start, but looking back, were matters you had to consider going down that path?
Yeah, I do feel that the clinic provided sufficient support and information to us throughout this process.
With respect then to the statement about the misinformation in the community, I guess that's the community at large, where do you think the source of that misinformation is coming from?
To me, the misinformation primarily seems to be in the once a person has gotten pregnant, and it's coming from obstetricians and midwives who are not necessarily up to date with the latest findings, particularly in the stillbirth space. That to me seems like the biggest challenge, and that's the purpose of the Safer Baby Bundle, to educate. I am a member of a number of IVF related Facebook groups, and there are often people asking, should I be induced? I've hit 40 weeks pregnancy, should I be induced because I've had an IVF pregnancy? And many, many people are responding and saying, no, there's no additional risk. I've been told by my obstetrician that it's exactly the same, which is really incorrect and really concerning to me. So the misinformation seems to be primarily, in my view, at the clinicians level. Yeah.
I think my time's passed, so I might have to leave
Yes,
other
I
questions.
think we're
Thank you
right
very much.
almost on 10:15. So, so that does conclude our time with you all this morning. But I just wanted to once again say thank you very much for being here. There might be some follow-up questions that committee members have for you after today or after we hear other evidence that we want to get your views on. So if that's the case, the Secretariat will reach out to you to talk to you about what that looks like. But once again, thank you so much for being here and for sharing so openly with us. It's very much appreciated.
Thank you.
Thank you for doing
We'll
the
have a
work.
short break now for 15 minutes, morning tea, and committee will resume at 10:30. So thank you.
Thank you.
Yep. Outside good? Excellent. Okay. Well, thank you, everybody, and welcome back. I wanted to acknowledge our next panel of witnesses and thank all of you for being here with us today to give evidence. I'm just going to ask each of you, starting from Miss Payne, just to swear first of all, state your name and your position title, and then swear either the oath or the affirmation. So,
Thank you. My name is Samantha Payne. I'm the Chief Executive Officer of the Pink Elephant Support Network. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Morning, I'm Dr. Fatima El Assad, the founder and the director of the Still Nest. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Good morning, I'm Karen Edwards, Executive Director of Clinical Operations at Gidget Foundation Australia. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Thank you.
There is a provision for each of you to make a short opening statement. So if you would like to, committee's in your hands. So again, we might start with Miss Payne if you wanted to, and we'll go down the list again.
Awesome. Thank you. Good morning, Chair, Deputy Chair and committee members. Firstly, thank you for the opportunity to appear before this inquiry and for bringing attention to an issue that for too often has been overlooked. At Pink Elephants, our purpose is simple. It is to ensure that no woman and her family walk the experience of early pregnancy loss alone. We believe that every woman should have access to validation, empathy and connection when she experiences a pregnancy loss. This mission to me is personal, and I share my personal experience now with an intention, because in the decade that I have worked in this space, there has not been enough change in how a woman is provided support within the health system when she suffers an early pregnancy loss, a miscarriage or a termination for medical reasons. More than a decade ago, I heard the words, "I'm sorry, there is no heartbeat." I was holding my then little chubby 2-year-old's hand, waiting to show her her baby brother or sister, only to be met with those words. It literally felt like the floor had opened up beneath me, but there was no one there to catch me. It was upon me to leave the sonography clinic, to make an appointment with a GP, to wait in a public waiting area whilst crying and bereft and not offered a private room of solace, to be given an emergency appointment because I didn't have a booked appointment, to meet a GP that gave me a yellow stick-it note with the words ERPC and a phone number for my local hospital, evacuation of remaining products of conception. Except to me, that was my baby. I had to phone my local hospital and to book in, to make an appointment to have an ERPC. It was Friday. I couldn't access an appointment until the Monday because within New South Wales and nationally we have early pregnancy assessment services that operate on business hours despite the fact that miscarriages happen 24/7. When I arrived at hospital, I was deeply triggered and confronted by women who were heavily pregnant, cute little babies in bassinets, shops that were celebrating the arrival of newborns. I was there to have my baby taken away from me. I left that hospital through the very same doors that I'd left with a baby in my arms 2 years earlier, yet this time I was given no referral for support, no access to emotional help, and broken by the silence that surrounded miscarriage. 6 months later, I would suffer a subsequent loss that was described as a natural miscarriage. Again, there was no heartbeat. I was sent home and I was told it would be like a heavy period. It absolutely was not. Confronted at 3 a.m. in the morning, I managed to pass that baby alone at home in the shower, again with no one to turn to for support, no phone number to call, no one to ask whether this was normal or health or life-threatening. I presented back to the hospital the next morning, at which an appointment, a junior medical officer managed to remove the remains of my baby that was stuck in my cervix, and during that consultation, placed my baby in a test tube in a kidney dish on the consultation desk in front of myself and my partner, and continued to discuss with us what our options were. Again, I left hospital with no referral for emotional support, no one to turn to, and then silenced by society's misperceptions on how miscarriage should be managed. Because at least it happened early, at least you were only 8 weeks, you've already got a daughter, you should be grateful. Returned to work and tried to pretend everything was okay. A decade of working in this space, I still hear stories that mirror my story today, and it's no longer good enough. Just 2 weeks ago, we held a community reference group and we listened to more experiences. And we heard from women clearly telling us they no longer wish to return to hospitals for healthcare when they've had a miscarriage because they do not trust the system. They do not feel seen, supported in any way. It's time for change. If 1 in 4 pregnancies end in loss, and again, we know that that's an estimate, then this is an urgent public health issue that deserves addressing today. And I thank the inquiry for any questions regarding the submissions and recommendations that Pink Elephants has put together. Thank you.
Dr. Elisar.
Chair, Deputy Chair and committee members, thank you again for the opportunity to be able to present our evidence today. The Still Nest is a special social enterprise dedicated to transforming perinatal and bereavement care through culturally responsive and respectful storytelling, advocacy, and community-led solutions for families navigating infertility, assisted reproductive treatment, pregnancy loss, and perinatal bereavement, particularly within culturally and linguistically diverse communities, migrant and refugee communities. The Still Nest, to our knowledge, is the only Australian lived experience-led organisation solely dedicated to providing culturally responsive perinatal and bereavement support for cowed communities, migrant and refugee families. Much of our work has been shaped by the stories from multicultural migrant and refugee communities that have entrusted the Still Nest through the Still Nest podcast, the Nest peer support community, the Poetic Nest, a culturally safe and art therapy space supporting grief and storytelling. Now, across cultures, faiths, and migration journeys, these stories consistently reveal both this deep yearning to build a family and the profound grief that can follow infertility, pregnancy loss, and perinatal death. They also show what culturally safe care looks like in practice, not just language access, but understanding how families grieve, what their faith and family structures look like, and how their trauma and migration experiences shape the way they encounter the health system. Cowed families in Australia face double the rate of perinatal loss compared to the general population, disparities that are systemic and preventable. Infertility and perinatal loss, which includes miscarriage, stillbirth, and neonatal death, are significant precursors to depression, anxiety, and prolonged grief. Yet culturally safe bereavement and mental health supports remain inconsistently embedded within standard care pathways. Based on our work across research, advocacy, and lived experience, I would like to leave the committee with 3 key messages. The first being that infertility, including endometriosis-related infertility, assisted reproductive treatment, pregnancy loss, and reproductive trauma must be understood as part of a broader perinatal mental health continuum. They can have profound and long-lasting psychological impacts, particularly where support is fragmented, inaccessible, or not culturally responsive. Second, culturally responsive fertility and reproductive care cannot be treated as an optional add-on. Equity must be embedded into system design from the outset, across interpreter access, workforce capability, multilingual resources, and the inclusion of multicultural voices in policy and service development. The third is that families require continuity. They require navigation and emotional support across the entire reproductive journey, not just at the point of treatment. Many cowed migrant and refugee families describe feeling abandoned between services, unsupported after miscarriage or failed cycles, financially excluded by out-of-pocket costs, and uncertain where to turn to for trusted information that is culturally safe. Our submission outlines 3 reform priorities aligned with these gaps. The first was the Local Health District Bereavement and Perinatal Loss Liaison Pathways. The second was Culturally Adapted Fertility Navigation and Equity Monitoring. And the third, a sector-wide perinatal mental health bereavement consortium. Now, since this submission, I'm pleased to say that the Still Nest, alongside Associate Professor Miranda Davies-Tuck at Monash University and Hudson Institute of Medical Research, has actually brought together more than 20 partner organisations, including the Pink Elephant Support Network and Gidget Foundation Australia, who are appearing alongside me today. Together with clinicians, researchers, cultural consultants, and lived experience leaders, we've begun to develop a coordinated and culturally responsive model of care for cowed, migrant, and refugee families in perinatal mental health and bereavement care. This work, currently unfunded, has also informed a broader MRFF proposal and reflects strong sector-wide recognition that current systems remain fragmented and that a coordinated reform across New South Wales is urgently needed. New South Wales is well positioned to lead here by building continuity, navigation and cultural safety into the systems and LHD pathways that already exist. The families I carry into this room today are counting on a system where culturally safe, responsive and equitable care is embedded into policy, service design and practice, and not left to fragmented services and individual organisations to navigate alone. Thank you, and I welcome your questions.
Thank you so much. Ms Edwards.
Good morning, Chair, Deputy Chair and committee members. Thank you for the opportunity to appear before this committee today. Gidget Foundation Australia is a not-for-profit organisation that exists to support the emotional wellbeing of potential, expectant and new parents through advocacy, education and service delivery aimed at preventing and treating perinatal mental health issues. Infertility, perinatal loss and the use of assisted reproductive technology increases risk factors for depression, anxiety and overall psychological distress. And as a national provider of perinatal mental health services, Gidget Foundation Australia sees firsthand the need for improved integration between physical and mental health care for individuals and couples accessing fertility support and assisted reproductive treatment. Mental health support during conception, pregnancy, early infancy, or following loss not only improves immediate health outcomes, but can also improve mental health and well-being during subsequent pregnancies. Individuals and couples accessing fertility support and assisted reproductive treatments face a myriad of medical, financial, emotional, and psychological challenges in their journey towards Planned Parenthood. The mental health impacts of the invisible load associated with recurrent cycles of anticipation, hope, loss, and despair can increase social isolation and may be exacerbated by feelings others do not understand their journey. But even the experience of a successful pregnancy can trigger anxiety and overwhelm, requiring specialist mental health support to navigate complex feelings and emotions amid unfamiliar and uncertain circumstances. And for those experiencing loss, there is no right or wrong way to grieve, meaning the supports required need to be uniquely tailored to the individual. It is crucial that health professionals delivering pregnancy, fertility and art services screen for mental health symptoms and provide timely support and onward referral. Expectant and new parents who have experienced grief without support will often present for psychological therapy in preparation for subsequent pregnancies, fertility treatment cycles, or even following the birth of a much-wanted baby, particularly when the anticipated joys of parenthood do not materialise. These presentations reflect the complexity and enduring impact of unaddressed grief and trauma for both individuals and families. Timely access to affordable perinatal mental health services to support parents through loss and any subsequent fertility treatment or pregnancy is therefore critical to the well-being of New South Wales families. But as grief is not a linear journey, there is no single prescribed model of care. Those experiencing pregnancy-related loss need access to a range of enduring supports which can be stepped up or down in response to triggers, stresses, and even positive life events, not just in the immediate loss period, but also as anniversaries come and go, potential milestones pass, and anticipated routines or significant occasions fail to materialise. The provision of trauma-informed care is also essential in helping potential and expectant parents feel safe, heard, and supported at all stages in their perinatal journey, and it should sit at the centre of all fertility and pregnancy care. Potential and expectant parents should be provided with a range of clinical care options aligned to their physical, psychological, emotional and cultural needs. Care should be decided collaboratively, provided holistically and offered without judgment. All New South Wales families deserve timely, accessible, high-quality perinatal mental health care during their parenting journey, from preconception through pregnancy to the postnatal period, and particularly following fertility challenges, assisted reproductive treatment or perinatal loss.
Thank you. Thank you all of you for the submissions and also for the incredible work that your organisations do. I think I speak on behalf of all the committee. You're known to many of us and we're very grateful. I also just want to acknowledge and thank Gidget, who have had support staff here helping for witnesses and potentially committee members as well throughout the hearing. It's been really grateful to have the support, so thank you. And Ms Payne, thank you for sharing your personal story, and we're really sorry for your losses, and it makes a lot of difference to the committee to have those lived experiences shared with us, so I just want to acknowledge that as well. The committee's resolved to have sort of free flow questions. We do have one member online. I'll just ask one and then I'll hand over because I could talk to all of you all day and have in other forums. But I guess for sort of the main issue that I wanted to get to was I think you've all talked about the importance of validating the grief that people go through when they do have loss and experience loss. But in terms of what, as a committee, we can recommend, and I'm thinking particularly around in that clinical sort of health and hospital settings, from all of the women and families that you work with, what are some of the sort of tangible things that the committee could recommend that would make that journey easier or different or better for people experiencing loss or fertility challenges from the perspectives of your organisations? And I'm happy for all of you to answer. So.
Awesome. I'm happy to start. Last year, the Pink Elephants launched a report, Not Just a Loss, and I'll submit that as evidence as well because it was just after the submission that we published that white paper. Within that, we launched the Pink Elephants Care Standards, CARE, for anyone that doesn't understand my northern accent. And they are very intentional to address the question that you've brought to us, and that is how can we provide more validation, empathy and connection for women in healthcare settings who receive unfavourable diagnosis or the loss of their baby. Validation often starts with language. We often hear from our community how they feel minimised in their experience because we use language such as D&C, ERPC, even spontaneous abortion around the experience of early pregnancy loss, and they don't align with those that terminology. So we think that language is really important. We also, again, as you heard through my story, and my intention of sharing that story is to hear that too many women and families are leaving healthcare settings without referrals for support. And this is critical because when you are a medical professional, you wear that white coat that basically signifies power. When a healthcare professional says to you, this is something that is worthy of grieving, that in itself is validating. That in itself allows you to stop and take the time and acknowledge what this is. Because when you live in a society that perpetually minimises the experiences, at least it happened early, or you can just get through it, don't worry, you'll get pregnant again, you can often internalise a lot of this, and that can lead to some of the poor mental health outcomes. So we'll submit that as further evidence.
Thank you. Yeah.
I'd love to second what Sam has just mentioned, and then perhaps just add the extra layers that families from migrant refugee and CALD community share with us. In addition to having that confusion as to what the next steps are and not really being able to navigate the hospital to home journey or the home to burial journey or whatever funeral arrangements are going to be made. They also experience, unfortunately, layers of extra discrimination within the healthcare setting. They will also feel a little bit...
That's just the lower house is sitting, their bells will ring occasionally, you can just ignore them, it's okay. Yeah. Sorry, keep it, please.
they also feel excluded by not only just the language in terms of the terminology and being clinical, but it's also in English. And often English may not be their first language, so it's already a confusing time, and they're not having any resources. And when I say resources, it doesn't just include language translation, but also a bit of a portfolio of resources that can be shared with the family to help them understand the choices that they've got to make, and empower them with proper education that's backed by evidence to support their next steps. So language, healthcare discrimination, but also the healthcare workers themselves. There is a need and a want to be very compassionate and provide cultural safety. But as I mentioned in my opening statement, there is no real perinatal cultural safety framework that they can actually work with. So they're at a loss. And every time I present in spaces where we're delivering some sort of cultural responsiveness workshops, the respondents or the participants come up to me and say, look, I really want to be providing that compassionate, safe, respectful care. But sometimes I feel like I'm going to say the wrong thing. I'm not quite well equipped. I don't even have a pathway to actually refer them onto. And what Sam just mentioned about not feeling validated, it's further exacerbated when a clinician and the patient both don't know. And since setting up the Still Nest, I often get a lot of messages asking me directly, like, what are the pathways? And that's, I guess, part of the main gaps that we've highlighted. Yeah.
I think both Samantha and Fatima make, really, really fundamental points that I would completely agree with. And I would probably add to their positions by saying that one of the things that we find is a genuine hindrance to help seeking is stigma. And in Samantha talking about the language, we know that language can stigmatise the way people view their loss. Even well-meaning euphemisms can minimise or downgrade the significance of what's happened and undermine people's capacity to seek help or to feel that their grief is normal or is to be expected, and that there is help available and that they should be looking to seek that. So I think stigma is a very big barrier, and the more conversations we can have, the more we can legislate pathways and minimum sort of service delivery standards that talk to open and honest conversations. I think the closer we get towards making parents experiencing loss feel that not only are there services available and that they can access them, but that they should access them, they are entitled to access them, and they will benefit from accessing them. And for me, even just on the way here today, I had a really interesting conversation in my Uber. The Uber driver asked me where I was headed, and he asked me what I was doing at Parliament House today. And when I told him, it opened up a conversation where he spoke about early miscarriage in his family and the experience of loss. He was a migrant, and he spoke about not knowing what pathways would be most supportive. And he spoke about the enduring impact of that on his family, right down to attachment issues following the birth of their first child after loss. And I think that just speaks to how much people want the opportunity to talk about this, to be heard and to share their loss and to feel that it will be dignified with supportive, informed, helpful information, care and response.
If I can just flow on from Karen's point, just briefly, she mentioned fathers, and I feel like, especially within migrant, refugee and CALD communities, not only are fathers not given the space in that room, but grandparents, siblings, and extended family mentors or parishes or spiritual leaders or, other important family members are not even registered as someone of importance to be able to be included in some of these conversations that they're having at the bedside.
I'll just add on that as well. In terms of, we're looking at stigma, and we need to consider intergenerational perspectives on this, and that what was okay for our parents and grandparents who went through women's health issues that were silenced and didn't talk about them doesn't mean that they didn't suffer in pain and lead to poor mental health outcomes. It just means that they literally were silenced. So I think we also need to consider education around the wider community on this topic, so that we can foster more empathy and understanding. Certainly on what Fatima's just said, in terms of our podcast, we know that a lot of listeners actually send it to family and friends because it explains to their loved ones what they're going through without them having to find the words themselves.
If I could just follow up quickly on what you were saying, Dr. El-Assad, about spiritual leaders, parishes, sort of the broader communities in which people operate. I'm just wondering if there are some examples you can point to of what called families would be looking for support. So, for example, I'm aware that Catholic parents are often distressed they don't have an opportunity to baptise the baby that's born before everything's whisked away. And are there other practical things like this that we should be promoting awareness of in the community and in the health system?
I really love that question because it is of great interest to me as I've been hearing a lot of these stories. Sometimes the families themselves don't even actually know. And in that moment when you're going through an infertility journey or you're experiencing losses or infant loss, that's when the added layers to their identity become a lot more important. So if they've been raised with a spiritual background or a cultural background, they start to think about, how am I going to honour my baby in my journey in a way that aligns with that? And maybe for the first time, they're trying to work out, who am I contacting in my local community to be someone that could guide that? And admittedly, I can't say that there is a model out there that is quite gold standard just yet. However, through the consortium that I mentioned, with Pink Elephants and Gidget and various other organisations across the country who are involved, I wanted to be able to create some community leadership from grassroots community organisations that have developed some of these pathways in collaboration with researchers and clinicians, so that when their community members do come to them, they have evidence-based research and pathways for them, so that they actually feel supported on their journey. Right now, it's very messy. It's very ad hoc. You're getting calls in the middle of the night. I can even share with my own lived experience of miscarriage and stillbirth that even though I need to check my privilege in terms of having English as one of my first languages, having a PhD in medicine, leading perinatal mental health research at an academic level, I too was on the phone after I had just given birth, naked, trying to figure out what the next steps were. So I really don't have a detailed answer, but it is something that we want to do collectively, so that no family and also no social worker, no clinician, no GP is unaware of a repository of some sort, whether it's a digital base that they can actually refer the patients onto to figure out, are you of this community, then these numbers or these spaces might be helpful to you to figure out.
What I would add to Fatima's comments, and you alluded to it in your question, is the importance of time. So for many women, who experience loss in a hospital or present to a hospital after experiencing loss, we know that our hospitals are, highly pressurised environments, and the ongoing pressure to turn over beds and to, discharge patients and admit new patients means that women are not always given the time that they need to answer some of those questions that Fatima has spoken about, to work out which way is up and what their next step might be, or to have an opportunity to speak to the people who might be best placed to help them navigate those next steps. So I do think that is something very practical that this committee can recommend, is that there is adequate time given for women to access support services within the hospital and to spend time just navigating next steps before they're discharged home and expected to navigate on their own.
If I may also add on to that. As part of the Pink Elephants Care Standards, we, and not just a loss report, we interviewed many key stakeholders in this space, and I want to acknowledge the work of Associate Professor Zoe Bradfield and Nicole Freeman from the University of WA on the role of the midwife for early pregnancy loss care and the continuity of care model. And I think that if we consider what we are hearing as pain points and problems, I feel like one part of the system that is overlooked is the role of the midwife and how they may be able to provide more continuity of care from a much earlier point. It is not to remove GPs and other health professionals, we still need those, but to address the fragmentation in the healthcare system, to address the need for a woman. I can't tell you how many women tell me how painful it is to retell their story to another health professional all the time. Even for myself, when I went in for my 6th pregnancy, which I did welcome a baby in my arms, I had to acknowledge every single one of my miscarriages myself. I had to write it on my form myself. And every person, some days I wanted to share that, other days I didn't. It's too painful. So I believe that if we can look at the role of the midwife and the continuity of care, they can also provide some time, but also an understanding of what's out externally that they can refer women and their families to that's culturally appropriate as well for them.
I think Dr. Con's got a follow-up.
Thank
on
you.
this issue.
I was planning a question that's really along these lines. No, it's helpful that you've opened that up. And I think there's the risk that I was hoping you could speak to. That, I mean, you've all compellingly made the case for additional support very clearly, and I think the risk is governments respond to that with a new service or a new program that then exacerbates that fragmentation problem. And as you've articulated so well, that fragmentation is not trauma-informed, that you're then asking people to retell their story and see a different program or a different service. So I was hoping you could speak to what you see as the opportunities for either bolstering existing services or integrating your proposals within the health system in a way that supports that continuity.
Yeah, 100%. I think the role of the midwife is definitely part of that is absolutely overlooked. I think we need to really consider how a hospital is best placed to provide support services. I know that there are pain points that I hear time and time again from women in our community presenting at emergency departments, literally miscarrying in ED toilets because there's no bed for them, there's no space for them. You have to ask yourself the question, what if that woman was given someone to contact or to have a phone call or a conversation with to understand what's normal and what's normal, to then be able to access an early pregnancy assessment service? That's taking a metropolitan lens. If you then look at this from a regional and rural, it's even harder because most of those hospitals do not have separate early pregnancy assessment services. But I can't help but think that we have services that work, but they are fragmented, and what we need to do is bring those together. And I do think that the role of the midwife is something that can absolutely make a difference, bringing more midwives into the early pregnancy assessment service. Do also think that we require some digital innovation here. We're in 2026, and I think that we still have things like yellow cards that then a woman is required to carry around with her. Considering things like that if and when the worst is happening, is that even with you? Are you going to have that with you? Then where do you put that information? I know from the communities that we face, there is that whole getting a phone call from the sonography clinic 2 weeks later because you haven't turned up for your appointment, but yet you miscarried that baby. How come the health system doesn't know that I miscarried my baby? Why is it on me, the woman in grief, to be able to make a call to tell them? Why should I be getting reminders? It's often placed on the woman who's going through the loss to bear that administrative burden and load, and we need to reframe that. So I think we need to consider it from two perspectives, not only the care and how we can use the systems that are in place, but how we can remove some of that fragmentation with some connection between those systems.
I think it's also important to think about, ultimately where people accessing care will continue to access their care moving forward. And so I think you make a very valid point that care is not always best placed to be from a hospital service because it's a start-stop relationship. So working out how we can better integrate community services and the care provided by those community-based mental health services into the hospital system, I think is a step that we can take. Certainly at Gidget Foundation, we do have a miscarriage pathway in partnership with our private hospitals, which allows the private hospitals to refer directly to our community-based services and for a clinician to come in and see that parent in the hospital where they've experienced their loss. We have opened our first partnership with a public hospital. It's a model we would like to see extended where mental health support for women presenting for a whole range of perinatal conditions is available at the point of contact where they're receiving their physical health care, and it allows them to continue to receive care in the community beyond discharge from that hospital environment.
Thank you. I know Ms. Hurst has got, but Ms. Savell also has one
Just
online.
in the interest of time,
Yep.
Chair, I'd be really interested in the model with Gidget integrating with the public hospital. If you could perhaps provide that on notice so we don't take up more of my colleagues' time.
I'd be very happy to do that.
Sure.
Thank you
We'll
very
just go to Ms. Savell and then Ms. Hurst. So, yep. Em?
Thanks. I was going to ask a question on that in terms of that level of integration, because as I understand it, there is a need for obviously a doctor's referral, and has that been removed from that process with the integration of that service?
For our miscarriage pathway, those initial sessions are philanthropically funded so that doctor's referral is not required until further down the track in their care, and that allows us to provide a more timely and responsive care pathway.
So it's not removed, just there's a workaround in terms of the funding?
That is correct, yes.
Is there a way that we can better streamline that, as in terms of having someone in the inpatient setting when they're seeing, just thinking about earlier witnesses we heard from, someone that delivers or has a stillborn baby, surely the doctors that they're interacting with in the service could then potentially automatically refer them on, or is that just not possible at the moment within
the current better access model? And I'm speaking from what I believe is my working knowledge of this. It requires a GP provider number, and so many of the medical professionals working in the hospital system will not be working from a GP provider number, particularly if they're employed by the hospital system. So that is the trigger. So the GP mental health treatment plan is associated with a GP provider number, and that's required for access to those better access sessions. That is my understanding. I apologise if that's not completely correct, or there are small details that aren't accurate around that.
look, I'm going to say it makes sense, but it doesn't make sense at the same time. So that explains it to me. Yeah. Sorry, did someone jump in?
Yeah, sorry. Can I add just something that needs to be considered? Early pregnancy loss is a bereavement experience first and foremost. It is not a mental health issue straight away. And with the right validation, empathy and connection, early intervention peer support is enough for the majority. And when we are talking about an issue that is at scale, we're looking at around 92,000 individuals each year in New South Wales, approximately. Again, we don't know the true number because we don't count. But we need to be mindful that there is a suite of referral pathways for different purposes, and allowing that individual the choice that they deserve. So, yeah.
Now, if I'm going to pipe in, just to nuance what both of them have shared for the cowed migrant refugee communities. So for us, we kind of appreciate that there is excellent work being done already, right? And some of these organisations already exist, and some of these referral pathways are already present, but the communities are not aware of them. So there's also a disconnect there. So part of that consortium framework, and what I mentioned in my opening statement, is to illuminate and map out these existing services and have them in an accessible format for communities of migrant, refugee and CALD background to be able to start navigating themselves as well.
While I've got you, Fatima, in terms of your submission, you talked about mandating called data collection and publishing disaggregated equity metrics within existing data systems. Can you just explain a bit more about that and how that would help?
Absolutely. So through the Still Nest, a lot of what I've shared is based on lived experience stories, and these are quite powerful, right? And we need data to be able to support these voices. And right now, the data isn't capturing things like early pregnancy loss or IVF cycles. It's not being disaggregated into ethnicity, family structures, and it hasn't even been designed in a way that is looking at it from a reproductive trauma-informed, culturally responsive sort of way. So a lot of the data that we are using to support a lot of our arguments today is a little bit outdated, and they're not collecting some of really crucial data, I believe, that would actually help support a lot of the reform suggestions that we're making.
So who is responsible for collecting this data if we were to make a recommendation around it?
It's a really, really good question. Do you want to?
I can add a little bit.
Yeah.
So from a national level, we know that the Australian Institute in Health and Welfare is looking at instigating a national pregnancy loss register. I can't help but believe that there also needs to be a state level of that. And what we don't want to do is add burden to clinicians, but surely there is a way that it can be as simple as this is what we are treating, we can note this, and then it can be captured in one place so that organisations like ourselves, so that government can inform service delivery. I mean, how are we meant to know the amount of early pregnancy assessment services that we need within this state if we don't even know how many women are going through early pregnancy loss here? It's basics. We've, for too long, in my opinion, looked away and accepted it as a standard 1 in 4. Yet just last year we collaborated with the Jean Hales organisation on the National Women's Health Study, and in the last 2 years of those women that they studied, 37% had experienced an early pregnancy loss in the last 2 years. So I actually suspect this number is much higher, and I do think the role the government has to play is creating a system that is able to measure so that therefore we can actually truly understand the number and begin to design systems that are fit for the quantity and also quality of outcomes.
Thank you. While I've got you, Sam, as well, just in terms of your submission, you talked about leave entitlements and workplace support. That's something that's sort of come up consistently across the inquiry. In terms of your recommendation around that, in urging the New South Wales Government to lead a campaign that showcases comprehensive bereavement policies, and training. Could you just explain a bit more about that and sort of what you would like to see in a perfect world?
I love a perfect blue sky vision. In terms of when we lobbied federal government for the Leave for Loss amendment, and at the same time New South Wales put through 5 days leave for bereavement leave. Unfortunately, a lot of that happened during COVID, so public awareness of it is still fairly low. We still have women coming to us not knowing that they're entitled to bereavement leave, so I feel like there needs to be an awareness campaign in that is actually accessible. Then we need to highlight best practice and gold standards, because what that does then is it works with private sector and it works with corporate organisations, small businesses as well, to help them to understand the need to provide bereavement leave, not only the requirements that they have to according to the Fair Work Act of Australia, but also the importance of it and how it can actually, it shouldn't be about data and it shouldn't be about numbers. However, we have things like presenteeism and absenteeism, and Pink Elephants has a workplace report that I'll also submit on notice. But within that, you can read all around the fact that we've got women showing up for work, but whether they're actually fit for work and performing their duties is another question. What is the cost of presenteeism to the workforce? Arguably, this is an issue that is causing that as well. And then on top of that, we've got issues like, if we consider a woman's age when she's going through reproductive challenges, it's usually when she's stepping up in leadership positions. And often what I hear qualitatively, and again, we don't capture the data, but what I hear is women stepping back from leadership. So women's workforce participation is being impacted every day because they cannot balance reproductive challenges, going through failed IVF cycle after another IVF cycle after another one, and then finally getting pregnant and then losing that baby. These journeys are not moments in time. These experiences are often profound and last for years for many in our community, and we need workforce to understand what their role is, because systems change isn't reliant just on government. Systems change requires the whole of us to come together to address this issue.
I would probably just add to that I think it's a really important visibility aspect as well. When we see women taking leave for bereavement, for reproductive treatment, we message other parents or potential parents that this is normal, that this is acceptable and this is okay. I still meet parents on a regular basis who don't disclose their pregnancy until after their 12-week scan, who don't talk about their fertility challenges or struggles. And the less visibility these issues have, the more stigma, the more shame, and the harder it is for people to access the support they need.
Thank you. Ms. Hurst?
Thank you, Chair. And thank you, first of all, to all of you for the amazing work that you do within your organisations. And thank you to Ms. Payne for sharing your personal story as well. In your opening statement, you said that it feels like nothing has changed in such a long period of time. And a few of us were just talking about the exact same idea during the break, that it feels like, you know, we've heard some of these stories years ago and we're still hearing the same stories now. What do you see as some of the barriers to getting that change? I mean, we've heard so many and we've seen so many great submissions with ideas around what does need to change, but why do you think we're so stuck in this position where, even after the birth trauma inquiry and the recommendations that have been put into place, that we're still hearing these absolutely horrific stories coming forward?
I think it's multifaceted. I think whilst we foster awareness and empathy within a situation like this and your committee, and I welcome that and that gives me hope, we need to make sure that this flows on into action. So recommendations are one thing, but I think that actually what we need to do is mandate some of these policies to be put in place. And I think that there needs to not only be recommendations, but there needs to be then a committee that comes after this that ensures that some of these processes are put in place to make the difference that we need to make. We need to move beyond talking and awareness now into a place of we're going to do this by X and this will therefore equal this. And I feel that once we start to have some of these policies in place that are making changes, that will then open up the gate for more that will happen. But it also needs a priority setting as well. Which are we going to tackle first? I mean, if we look at the UK, for example, obviously you can hear an accent. I'm originally from there, but I'm a proud Australian citizen and have been here nearly 20 years. However, the UK had a government review. 73 recommendations were made. That was now nearly 4 years ago, and they are still fighting for a lot of those recommendations to be put in place. We cannot let that happen here in New South Wales. We have a huge opportunity here, and what is needed is actually some decisive and quick action and some policy wins that can build momentum, in my opinion, that can foster more in the future.
All right, I'll do a little quick one. I mean, obviously, I second everything Sam has said. We're pretty much in alignment, I think, in terms of how we would approach things. But if I could just throw a curveball and say preconception health, really going back to those younger education years. So we know that, at schools, I know it sounds quite bold, but let's get it in there. Let's talk about reproductive sexual health and really get down to adverse pregnancy outcomes and not just teach them about the stuff that we've all learnt, and we know that that is really 1% of our experience. And give them proper evidence, proper education around really what is going to happen on your journey or potentially what could happen on your journey. So, and start young.
And like Fatima, I wanted to build on the upstream educational approach. I also think it is the education of our health professionals. Their very early training. Certainly, whilst we've all heard some of the horrendous experiences that people have, we also have all, I'm sure in our professional experience, come across people who have experienced very compassionate care, very trauma-informed care, care that we would consider to be gold standard. But what is concerning is that that relies on the individual health practitioners that they perhaps come in contact with, or the individual health services and systems and local policies and procedures. What we need to see is consistency. Consistency in the education that our health professionals receive, and that's all health professionals that provide the care. We also need to see some consistency around the expectations of what health services should deliver and how their staff are educated, kept up to date and informed about what gold standard care looks like and how we might give them the tools and resources to implement that, because I do recognise as well that very often even very well-intentioned, well-informed health professionals will struggle to deliver the care they would like to provide in the absence of adequate resourcing.
Can I add on that as well? I think that it also comes back again to data. Fully commend what both of you are saying and support that. But if we actually measure the number of pregnancy losses, the number of failed IVF cycles or ART cycles that are happening, then perhaps we can attain some goals that we can measure and benchmark against in the future, rather than, if I just come to mind, you look at stillbirth and there is an action plan, a national action plan, and there is even a target to reduce the number of stillbirths. Yet with early pregnancy loss, we can't set a target because we don't know how many actually happen. And I can't help but think the two are very interconnected, that once we have the data, therefore that will almost in a way enforce more action and more change that we want to see as well.
Can I just add, it's that continuum idea that I mentioned earlier. So we kind of attack or target things in such a fragmented way, and then there are all these gaps that kind of emerge because no one's reproductive journey is just a pregnancy loss. There might have been an infertility journey before that or not. It might have then resulted in another subsequent pregnancy after loss, and that requires a lot more support from a perinatal mental health support. I mean, I could go on, but it's just really thinking about it in a more of a continuum way to actually get more bang for the buck.
We
Run out of time?
we have, but again, we could keep going for a long time, but we might have to pull it up there because we have got a few
I'll
minutes.
put some questions on.
Yeah, thank you. Thank you all so much. As I said, we probably could have had you for longer. There might be some questions. Ms Hurst, Mr Donnelly might have some too, that we will put to you on notice afterwards, so the Secretariat will be in touch and ask for a written response to those. But thank you very much for your evidence and for your submissions, and we really appreciate your insights. So thank you.
Thank you for your time today and for your genuine commitment to making change in this space.
Thank you.
Thank you.
We do now have a short break. We're back at midday, so we'll see everybody back. Thank you. Yep, outside. Great, excellent. Well, welcome back and thank you to the next panel of witnesses who are here with us today. I just wanted to start by asking each of you to please state your name, your position title and swear either an oath or an affirmation for the committee, and we'll start with Dr. G.
Thank you. My name is Dr. Alison G. I'm the President of the Australian and New Zealand Society for Reproductive Endocrinology and Infertility. I was actually also invited but was not able to attend as a RANS, Royal Australian New Zealand College of Obstetrician and Gynaecologist representative 2 weeks ago. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Hi, my name's Professor Antoinette Anazodo. That's my maiden name and a name I practice in for the last 20 years. My official legal title is, my surname is Friend. I'm a paediatric and adult dual trained oncologist and I look after children at Sydney Children's Hospital. So I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Thank you. Associate Professor.
Hello everyone. My name is Yasmin Jayasinghe and I'm a paediatric and adolescent gynaecologist at the Royal Children's Hospital Melbourne and the Royal Women's Hospital, and I'm co-chair of the Australian New Zealand Consortium in Oncofertility, and I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. There is an opportunity for each of you to make a short opening statement to the committee if you would like to take that opportunity. Dr. G.
Thank you. Well, I would just like to thank you for the opportunity to participate today, and ANZREI welcomes this opportunity to provide further response to the New South Wales Legislative Council into fertility support and assisted reproductive treatment, and I'm very comfortable taking any questions that you might have and to offer my experience with respect to access, affordability, equity, system design and surrogacy.
Great, thank you. And either or both?
Yeah, so I was just going to basically provide an overview of what we're talking about. So basically about 1,500 children are diagnosed with cancer every year in Australia, and the survival is improving over time, so about 80% will be long-term survivors. The good news is that when we think about cure, it's not just about making sure they're long-term survivors, it's making sure that all aspects of their life are able to be lived, and that includes, when they're older, having the opportunities to have a biological family. So Oncofertility is a service where there's collaboration between oncologists like myself and reproductive specialists that you have in the room, coming to think about what is the risk of the cancer treatment and what are the things that can be done in terms of fertility preservation to prevent infertility, or to have opportunities for using those gametes or gonadal tissue. Now, we know that the best chance of having biological children is by thinking about fertility preservation at the time of diagnosis, so that you can have opportunities for fertility preservation. We also know that cancer treatment is changing, and so the era of precision medicine with new novel therapies, small molecules immunotherapy, and targeted radiotherapy is also leading to impacts for fertility as well. So we still, while we have more survivors, we still have to think about the impacts in the survivorship era, and that's why we're here today, to think about how we have models of care that allow children and young adults, these also apply to our adult population, to have opportunities for biological children in the future. What needs to change in terms of the current systems to meet the parental and individual patient expectations, and how we have the right governance to sustain the practice.
Thank you.
And I'll just say a few words as well. Thank you. It's a real honour to be here and to talk about oncofertility from a paediatric perspective. So I echo everything that Antoinette has said. We work very closely together. I would say that this is a very rapidly moving space. When we first started, there were many, for example, procedures that were considered experimental. That has changed rapidly. And I think that our legislation has, the pace of medical practice, I guess, is moving faster than what the legislation has kept up with. There are two areas in particular that I'd like to highlight. One is the legislation around use of reproductive tissue in minors, and also around accreditation of providers in oncofertility. So traditionally, this has been an adult space, IVF clinicians. Oncofertility is very multidisciplinary, and there's clinicians from all across the paediatric and adult sectors now. And I think we do need to address that as well, because currently the legislation recognises FSA accredited providers.
Thank you. So the committee's resolved just to have sort of free flow allocation of time, and members will ask. We've also got Ms Savelle online as well, who you can see on your screen, so she'll pop up there when she has questions. I've started the last couple of sessions, so I might hand over if someone else in the committee wants to. Ms Hurst, do you want to start?
Thank you.
Thank you.
Thank you, Chair, and thank you all for coming today, and thank you for the amazing work that you do in this space. I'm curious, in full disclosure, many years ago, in a previous life, I worked at the University of Western Sydney in regards to research around people who are undergoing cancer treatment and whether or not, doctors were having the conversation about their future fertility and how much their treatments would potentially affect their fertility. And the research back then was showing that sometimes those conversations weren't being had. I'm just wondering if that is still the case, and with particular cultural groups or other groups, if that is still a potential concern that is still in this space, and whether people are still sort of coming out at the end of cancer treatment and finding out that their fertility has been affected when it's too late to do anything about it.
Yeah. So, look, there's lots of publications about the information that families receive. We know in 2024, which is about the sort of most recent publication, that 25% of families have to bring up the concept of infertility or risk of fertility. And about 50% of patients are given information by their providers. Now, there are some caveats to why people get information and who gets it. So in centres where they have expertise, they're more likely to receive it. In centres where the providers are comfortable and they have experience and education, they get it. And remembering what hospitals are like, there's change every 3 months with junior doctors. There may be some senior providers who have religious or cultural reasons why they do not want to talk about this, or they don't feel comfortable. There's a difference between male and female information provisions, and then there's a kind of, I guess, way in which people can be paternalistic and go, well, if you don't have money, why am I bringing up something that you can't afford? And there's a lot of data around that. And then the last area, I guess, is our called population. So our cultural and linguistic families are less likely to receive information. Our rural families are less likely to receive information. And those families where they may be part of the LGBTQI population, based on, we've done a very big series of studies called Out With Cancer, are less likely to receive targeted information, even though there are some providers that specifically provide care for that population. So, we still in Australia are struggling, one, because of information provision, two, because of access. Over 90% of fertility providers are in the private domain. So if you imagine your cancer diagnosis is going to more likely be in a public hospital or a private-public collaboration, then getting access to these facilities is going to be proven to be difficult. When we've done studies looking at public cancer services that have an oncofertility model of care, it's still less than 10%. So that means a collaboration with a private or a public fertility provider, and that is the challenge that we have.
We also heard this morning that people who find out that that they may have a very quick need to kind of make a decision whether to retrieve and freeze eggs, for example, and I assume that would come up quite a lot in the cancer treatment space, aren't able to sort of access private health care because they're not on the top tier of healthcare and they have to wait 12 months. I'm assuming you've heard sort of similar barriers that, or other barriers where people are unable to still take action when they've got that cancer diagnosis and that very short time frame.
Look, the diagnosis of a cancer is complicated, okay? So you've got to first identify the cancer, then you've got to stage a patient, then you've got to do what we call toxicity screening. That's where you just check heart is fine, lungs are fine, put the central line in, okay? At the same time, what should happen is you talk about the risks to your organs, and fertility is an organ, right? So if you can start and have the discussions at the same time as you're having the discussions about staging, then there's usually time. Okay. Obviously, there's some patients in intensive care very sick. They're not going to be ideal candidates for fertility preservation, but you can still talk to family, partners, parents, and then come back later when that patient is better to go, okay, have we got a second opportunity? The difficulties we have is, one, obviously, first you have to have the conversation. Secondly, you have to be in a centre or be referred to a centre that can do fertility preservation. Then, in New South Wales, not true for all the states, there is access to some public fertility preservation, but there isn't enough money for those services, so there is waiting lists. So obviously, in New South Wales, we want to start from the time of a cancer diagnosis, GP referral to starting a cancer diagnosis, we've got 4 weeks, okay? So if you don't have a service that can do fertility preservation in a timely way, you either have to wait, and that's not ideal, or you have to start cancer treatment before the fertility preservation starts. The other options are you either have money and you go to a private provider, okay, or for a majority of patients who don't have the money, they have to think, okay, can I borrow from mum? Can I use my super? And again, it's not ideal. In Australia, we are thinking, what can we do to ensure that they are not going to be using private public money in the future in a larger capacity? So if we can preserve fertility before the cancer treatment, we're hoping that they're not going to need to either use more complicated methods of trying to access tissue, or the quality of the tissue is going to be good, and so they've got a better chance of IVF working, and that's where you've got specialists who can talk through that. So, absolutely lots of challenges. Or if you look at, I've written lots of publications about model of care, we should be able to address in Australia, but we're still struggling in 2025, 2026 to address.
Thank you. Can I, it sort of follows on a little bit and it brings you in, Dr. G, but just the I guess complexities around sort of cancer patients and what you've just alluded to, Professor. But in your submission, Dr. G, you talk about the importance to have the title fertility specialist to be protected, and some of the concerns, I guess, around others sort of using that phrase without sort of having that same clinical level of training. Can you just talk to the committee a little bit more about why it's important to have that distinction recognised and maintained?
In terms of recognising, I suppose in terms of model of care, there's quite varied models of fertility care. So obviously there's a first appointment with a general practitioner who'll do some investigations for both a male and female partner. The next level of care will be a general gynaecologist, and who may not have done a lot of fertility training, but very happy to help with ovulation induction and some very simple methods to try and enhance opportunity for pregnancy. And the next level of care may be a gynaecologist who's done some training in fertility and who may be well versed in many of the aspects of fertility care, and they may also entitle themselves a fertility specialist. It's not a protected title, fertility specialist. And then you'll have those clinicians who've done additional training who have certification in reproductive endocrinology and infertility, and that's a college subspecialty, and that is an additional 3 years of training, which is the Australian New Zealand Society for Reproductive Endocrinology and Infertility, for whom I've been asked to represent today. And so that's an additional 3 years of training, research project, and so I think the exposure in that 3 years does provide a lot more depth and breadth of knowledge, particularly when you're talking about oncofertility. And so it is important that title is often recognised so that patients are understanding, for some patients, where they're getting their information from and is it the right information for them. Just touching on the issue about service provision, I think the public hospitals where a lot of training is done in New South Wales in terms of reproductive endocrinology and infertility specialists, and we're very lucky to have 3 public centres in New South Wales that provide those services, 2 of which I have trained at myself, Westmead as a fellow and Royal Prince Alfred Hospital as a fellow as well, which are excellent training centres. I think the exposure that you get during that period of time to oncofertility and the need and the actual connections that you make with the departments provides is very important continuity of care, both in the public and in the private sector, when clinicians may move into the private sector as well. So that's probably the differential in terms of fertility specialist. It's not a protected title. It could be a range. You may have even some ancillary health providers labelling themselves as fertility specialists it could be in various, naturopathy or acupuncture. So you could be seeing yourself as a fertility specialist in those aspects. So I suppose for patients it's sometimes it's maybe difficult to get clarity around that particular title in terms of what is a fertility specialist and how do we see a fertility specialist from a community perspective, from a professional perspective. But that is the difference between those who have certification in reproductive endocrinology and fertility. They are trained obstetricians who've done obstetrics and gynecology training and have gone on to do that additional training through the college.
May I comment on
Please,
that?
yeah.
Thank you. I really appreciate the conversation because we were talking about coverage of discussions earlier, but I'd like to really highlight quality of discussions. And what our families tell us is that it's not just whether they might not have even recalled a discussion, but that for the ones that did have a discussion, the quality was suboptimal for them. I do honestly think that for the paediatric and adolescent space, it's very important to have a multidisciplinary approach, including fertility providers. But in the paediatric spaces, it's a multitude of providers that might need to be involved. You've got your oncologists that might need to raise the issue to begin with. We've got paediatric providers that assess level of, stage of puberty, for example, which is quite important for prepubertal boys. Clinical ethicists, and so I think that has led to, oncofertility being a little bit separate to fertility interventions, I guess. And so the quality of consultation in oncofertility is really important. It's not just a checklist at all. And I think in the paediatric space, patients have, there are oncofertility disciplines and services led by very multidisciplinary teams worldwide. In the Global Oncofertility Consortium, for example, over in the US, you've got pediatric urologists, you've got, reproductive people, pediatric gynecologists. But if they're embedded in the field, I think that's important. And what we don't want to see is just a checklist and someone saying, we've discussed fertility, refer.
Yeah, because it would be highly contextual as well.
Yes, adolescent specialists as well. And discussion of, even, sexual health. It's a very, very holistic kind of service from the beginning, from diagnosis right through cancer treatment to beyond and during survivorship.
Again, the other group that we haven't talked about is our general paediatric surgeons.
Yeah.
So we have oncology surgeons who are routinely doing operations, including operations on children who need ovarian surgery. Okay, so I absolutely agree with both my colleagues' statement, but I think it's really important to have some sort of way and we can ensure that the paediatric providers, whether they be urologists, paediatric surgeons, have the expertise, have the training to be able to do that type of surgery. So in my centre we've got I think 8 or 9 paediatric surgeons. Only 3 of them would do paediatric oncofertility surgery because if they're prepubertal they're not going to have IVF, they're going to have a collection of either a whole ovary or slithers of the ovary that can be collected, analysed and put into storage in the freezer for later, where it could either have the follicles or eggs removed and used for IVF, or reimplanted to allow the hormonal production to start again and then have IVF. So certainly there are general surgeons, I don't know whether Dr. G would agree, who are doing that and who would have the expertise for doing that, but we just don't want any surgeon to think, oh, I can do that, I'm sitting in my hospital in X and I've done something similar. And that's where these pathways are really important. The accreditation is important and the follow-on to say, okay, what is the quality of what's happening? We don't want, if you think the average age in Australia of your first child, if you're a woman, is 30 years and 3 months. If you're a man, it's 30 years and 7 months, okay? So today I've just seen a 5-year-old in my clinic this morning. They've got another 15 years before they're thinking about having their first child, okay? So we need to not only give information and make the right decisions about fertility preservation, but we need to make sure that the tissue we are collecting is optimal and is stored in a way that allows the longevity, okay? And they're the sort of problems that we're grappling with. How can we make sure that the service provisions are such that the education, the governance and the right people are doing all of this?
There also needs to be an assessment of the medical risk and comorbidity, and for paediatric, so some kind of expertise in paediatric oncology, paediatric surgery, paediatric gynecology to assess those risks is really important. So when we think about providing oncofertility services, there's a few things. We feel that they're absolutely permissible. They are consistent with, our human rights, policies. But the important thing is that, well, what is the degree? Can someone accurately assess the degree of infertility, the risk to fertility for this patient? Has someone understood the values of this family? That's absolutely vital. What is the risk of going ahead? Is this a low-risk procedure or is this a high-risk procedure? And what's the chance of this young person being able to actually utilise the gametes or the tissue moving forward? And what is the chance of that by the time they're a parent, they're actually able to use that tissue in a appropriate way?
Yeah, thanks. I wanted to ask about accreditation and regulatory oversight, which of course has been topical at a federal level, and this committee has already heard about the broad range of IVF and other ART providers in the community, mostly in the private sector. Some of them are excellent, but obviously there are really varying results, and I'm interested in each of your views on what we should be looking at a state level in terms of accreditation or regulatory oversight.
Well, one of the things I can talk about is data. Okay, so as my research hat at the University of New South Wales, I host the first oncofertility registry. It's called Future Fertility. Okay, so that really, I feel, in order to know what we're doing right and also know when we need to stop doing things, you have to have data. And I think data needs to be built into the accreditation process, so we can look at things like are we targeting the right patients? What is the time frame? What are the complication risks? And what is the benefit? And I think at the moment where there is no, while Dr. G will talk about RTAC accreditation and accreditation for safety. So we're doing that, but we need to, from an oncofertility point of view, be able to link the oncology data and the fertility data to be able to say, okay, well, actually, we know that this is safe. My research shows it's safe to do fertility preservation, but there are 1,500 children and young adults, and we've done 300. Why haven't we done more? Okay, because what we don't want to get all the litigation, and there is building litigation for young people and adults who are coming back to saying, I never had the conversation, I wasn't given the opportunity. Or we don't want to, be at the end where we're saying, okay, that person didn't have fertility preservation, and therefore now we've got to try and do those procedures with a lower chance of success. So I think data is really important. From an oncology point of view, we obviously don't have accreditation for fertility services, and we don't have accreditation for the communication services. But yet, an oncologist is integral for patients knowing about fertility preservations and making the referrals. These patients don't tend to go back through their GP because they're already in a cancer service. And I'm, as an oncologist, are going to be telling the patient, I should be telling the patient, there's no risk. There's a small amount of risk, less than 20%. There's intermediate risk, so 20 to 80%, or there's a high risk, okay? And so data comes back to data, right? New novel therapies, what is the data for that drug causing infertility? And a good example is melanoma. Melanoma, until, the poach funding, was an incurable disease if you had stage 3 or stage 4 disease. 10 years later, we have more and more survivors, okay, with immunotherapy. So what do we know? If a patient came to me today, I should be able to say, oh, this immunotherapy is going to cause or is not going to cause. So it means that we have to constantly be doing research about new therapies, okay? So that's another thing. That's the impact of drug companies. Are they allowed, or should they be allowed to miss out fertility or the effects on the unborn child? I don't think they should. I think that should be ongoing research that they're doing. I think we should have data to long term to collect and find out what's happening to the young people and adults who are undergoing IVF. And we also want reassurances that having IVF does not cause cancer. And again, there's big data sets now showing it's safe. So I think that's, from my perspective, what I would say.
I would say that it's really important that clinicians are able to practice in an area of certainty. They need a landscape of certainty to practice. And if they feel that the laws don't really look out or cover them, then they'll be really resistant or fearful of actually being involved at all. And that's really how a lot of patients can miss out on these conversations. The reality is that not every single oncology patient can be referred to a fertility specialist, particularly patients who are at low risk of infertility, or a patient who's very, very unwell and needs to start their treatment immediately, and there's no time for seeing a fertility specialist or doing any fertility preservation. It is important that all providers have some kind of, they are covered, through legislation and being able to be accredited. At the moment, we've got FSA accredited providers who are IVF clinicians, but now, fertility is changing, and oncofertility does happen in a pediatric space as well. And at the moment, we've got, the consortium has got a grant. We're developing national guidelines, ANZCHOG guidelines, the first paediatric specific guidelines for Australia. And we've done, we've just published some work on accreditation for surgeons. But, we do think that needs to be implemented, and some kind of national standard would be great. So, we've got our guidelines. We've got now just about all paediatric centres have got SOPs now as a result of, this work that we're doing together. But the middle bit is a national standard. And, often guidelines can stay there for 10 years and nothing happens. But having tools that help clinicians do the right thing is really vital, and I would really advocate for a national standard, including accreditation standards, so that patients get high quality care.
Thank you. Look, what I would say is Australia does have really internationally strong assisted reproductive technology outcomes, and we should be very proud of those. Both ANZRI and RADSCOG do support strengthened national consistency in assisted reproductive technology and its outcomes. And part of that lies in the fact that there is very variable legislation surrounding assisted reproduction throughout Australia in the States. And this is both with particularly with donor conception and with surrogacy. And that does make it very difficult for patients navigating assisted reproductive technology and building families within states. For example, some states will allow a donor to provide for 5 families, including their own. Some states might provide for 10 families. The surrogacy legislation is very varied within the states in Australia, and also how those states view overseas surrogacy arrangements. The Australian Law Reform Commission is currently conducting an inquiry into surrogacy within Australia, and I think for the states individually it would be important to look at those outcomes or those recommendations when they come out, because I do think the strength or the way to strengthen our assisted reproduction technology within Australia is to adopt a national approach to guidelines surrounding surrogacy, surrounding donor conception, I think also surrounding transparency in reporting and outcomes. I think that remains very important. Similarly with our databases, I think national databases, there's enormous strength in having those for both patients and clinicians, and that helps drive decision making in terms of new technologies and also therapies for patients. And I think it also makes it much easier for patients to navigate the system. And that is often one of the difficulties that you've heard today in terms of even oncology, a cancer diagnosis, where do I go? Where do I get help from that? I think very clear pathways for navigating into the public system very readily, where it's funded and well supported, is very important. I think rural support in New South Wales for patients in remote areas, disadvantaged patients, remains very important, and I'm a very strong supporter of the public health system to help facilitate and provide that. And I think that needs to be strengthened across a national base. And we have a very good starting point in Australia. We provide very good technologies. We have excellent training, and I think that consistency across all the states will strengthen that even further.
Just looking to the Labor members, maybe either Ms Savelle online might have questions. Thanks.
Thanks, Chair. Thank you too for appearing today and for your excellent submissions. Excuse me. My first question to Anne's Co. In your submission, you talk about, excuse me, I've got a frog in my throat, the implementation of guidelines and nationally consistent guidelines, and I think you spoke about that work being expected to be completed in early 2026. Is there an update on that, the national guidelines?
Yes, yep. So in July, the Guidelines Group will be hosting a large meeting where we will refine our evidence summaries, and so we expect that to come out this year. We have a group of 70 on this from across Australia, and doing 52 systematic reviews on questions related to oncofertility.
That's a lot of systematic reviews.
Yeah, it is.
In terms of that piece of work, do you think is there anything involved in that process that could be or would be relevant to this inquiry in the terms of reference?
Yes, I do think that, I'll come back to the legislation again. I think one was around accreditation. I think the other thing is really around the tissue itself. At the moment, the laws across the states are variable. It's permissible to collect and store tissue according to, New South Wales, Victorian legislation, and HMRC ethical standards. What happens from that point onwards is a grey area. And, for example, in New South Wales, we wait for a child to reach maturity to make a decision. In Victoria, it's even a little bit more restricted about what can be done with that tissue. And it can be used for the benefit of the child, but that is down to interpretation. And so we really do need support from our legislators around that issue, because, for example, if that's interpreted, for example, the way that we use tissue, what we do with it is mostly to implant it back into the body so that it gets the blood supply, matures, produces eggs. But if there's any questions around that, if that's considered research, then, some laws say that you can't do research on tissue of minors, and then we're stuck. We've got this roadblock. And the roadblock, unfortunately, is not in the best interests of the patient. We're doing all this work to protect their fertility, and then we're getting to this stage, and our survivors are now actually getting to reproductive age now and are asking. And that is something that we would love to have clarity on, because, again, clinicians really don't want to practice in areas of uncertainty.
No, look, that's understandable. Tell me, is there a lack of clarity around whether that is permissible within New South Wales in terms of the removal and reimplantation of tissue?
New South Wales suggests that you could, once the young person becomes an adult, they can decide what to do with the tissue, but there could be local institutions, for example, or, that might consider this as research. So I think there's still there is a bit of a grey area there. It would be great to have some consistency across the states and some certainty. You could probably argue that it's fine, and in Victoria, you could probably argue that it's fine, but we're getting to that stage now where we're wanting to, for example, at the Children's Hospital with our onco-fertility program, we implemented the first onco-fertility program for children, and we recognise that the surgery itself, that's not experimental. We do surgery on gonads all the time. We understand the risks. So we've got different levels of governance. We've got institutional governance as a novel technology to collect the tissue. We've got research governance to do all the monitoring and around that. And we've got clinical ethics governance where we have individual oversight over, each decision more or less. And so, and we felt that gave even more governance than research governance alone. And a model like that could probably work when it comes to grafting as well. But there's really, we're just negotiating that at the moment.
Yeah, thank you. In terms of your submission, you also talk about male factor infertility. And we've obviously got a panel of witnesses coming up next that will likely speak directly to this. Yes. But I just wanted to get your comments around this in terms of items 7.2 in your submission, where you strongly urge us to consider male factor infertility.
I would defer to the male infertility experts on that. One thing that I will just quickly say about testicular tissue transplantation, because it is an area where, it's probably the last frontier in oncofertility with respect to being able to restore fertility. So, for example, when you collect eggs, we've now got, it's very well established. Ovarian tissue has also transitioned from experimental to standard practice. With testicular tissue, the use of that tissue is considered experimental. Just a few weeks ago, there was a publication on
Scottish publication.
Belgium, actually.
Oh, okay. Well, there's
where
another one today.
yes, oh really? So where they've actually been able to develop sperm from testicular tissue in prepubertal boys, and that we've been really waiting for that. So it is considered experimental, and I would just say that undertaking testicular tissue cryopreservation should be still undertaken under strict governance. We wouldn't be, promoting that as just standard practice.
So agree with that. I mean, again, today the Edinburgh group, Rod Mitchell, produced a publication showing, again, in their group, the first prepubertal patient 15 years later who has an implantation, and he's producing sperm, which is amazing. I guess there's two things. The first is it easy and doable to collect tissue? And I guess all the groups say it is something that can be done easily with very, very low side effects in the context of experimental processes for males. The same for females. In 2018, both the European Society of Reproductive Medicine and the American Society of Reproductive Medicine, supported by our own Australian society, have said it's no longer experimental for ovarian tissue to be collected and to be used, because there are more than 200 babies that have been born from that technology. Okay. Now, in males, I've already said that the average age for your first child is 30 years and 7 months. And so what we're saying is, in today's 2025, can we do anything in the future to potentially prevent that person being infertile or having an opportunity for a biological child? And, yes, the reimplantation aspect is research, but the collection of tissue actually isn't research. It can be done safely. It could be done prior to a cancer treatment starting, and it may actually prove to be useful, knowing that already in 2026 we're getting case reports of data suggesting that this technology, like the female technology, is actually going to be successful. So, I guess that's the sort of an ethical question. Do we just wait another 5-10 years to see whether it truly is going to be successful, or do you allow the collection for the possibility in the future, when these young people are adults, and if it is successful, to have that opportunity? And I guess that's where we have to decide as Australians where we sit with ethics, and there's also that sort of the factor about communicating to families. The families I see, are mixed. There are some families who just they want everything, and they want the possibilities, they want the hope, they want to be cancer survivors. And there's others that saying, look, we're not interested in the experimental aspects, we just want to preserve fertility in the basis of something where there is real data.
Thank you. It's fascinating
Really
work. I wonder if you could just, in terms of an access question, whether this is now just run-of-the-mill provided to all patients that you see in public settings across the board, or is there still work to do in terms of ensuring that all paediatric patients that are potentially undergoing these sorts of therapies can access this?
So in New South Wales, we have 3 paediatric oncology services. So Randwick, where I work, Westmead Children's, and then we also have John Hunter. So John Hunter does not have access to fertility preservation services as a public service. There is private fertility providers, or they have the opportunity to come to one of the other 2 services where they can have their staging and fertility preservation started and then go back. Obviously, if you're a Hunter New England patient and there's a large catchment area, that adds additional cost and psychological stress. Okay, in terms of the 2 children's hospitals in Sydney, I would say there is still a quite differences in access. The service at Randwick has been going for a long. In fact, both hospitals have a fertility services that have been going for a long time. The service at Randwick is well embedded in the paediatric service. The service in Westmead has been slower. We have ongoing meetings to see how we can work together. And part of the problem is the Westmead fertility service is a private provider, and it's again the difficulties when you've got public and private providers trying to work together. So, that is a work in progress. At the moment, many of the patients from Westmead are coming to Randwick for their service. When I do not have anything against private health care, and I think a lot of cancer care does happen in the private sector. One of the things that is important to realise is what we want is not only people to have access to fertility preservation, but to have timely access, so it's happening at the same time as your cancer diagnosis workup, okay? And it's happening before your cancer treatment starts. Part of the problem with the private providers is they sit outside hospitals, and Dr. G can talk to this as a reproductive specialist. So that means that there may be many of the patients who actually are not good candidates to be in private clinics outside of private hospitals. And so for example, if you've got a young person with leukemia, who has slightly lower counts, who's prone to infection, a person with a mediastinal mass, you want them to be in a quaternary service that has access to good anaesthetic care, to surgical care, to the reproductive specialists, all collaborating, all working together with access to a good blood bank. Okay, and that's where we struggle when we're thinking about our rural remote partnerships and some of our private clinics that sit outside private hospitals. Even within the private hospitals, I don't think there are many private hospitals with fertility services. So that is the challenge. In 2018, I put a submission with Professor Bill Ledger, who's now retired, for our public oncofertility service, where we had funds that were given for this service at RPA, Westmead and Randwick. That has largely been very successful, except there really isn't enough funding to provide for all the cancer patients who need it, and that is part of the challenge we have.
I think Mr. Donnelly just has a word. We're slightly over time, but I'll let Mr. Donnelly.
And thank you all for coming along, and thank you for your submissions, which have been very helpful, plus your evidence today. And in the evidence today, you've spoken about research work that you've all been involved with. And I think most of you, if I'm correct, have been involved in direct research work in some form or another. Is that?
Yes.
Yes.
Does that involve you, Dr. G, as well?
Yes. I'm not actively involved in research at the present time.
No. Now, with respect to the research work, you'd be all aware of the NHMRC's ethical guidelines on the use of artificial reproductive technology.
Yes.
Familiar with those guidelines?
Yes.
And they're quite extensive in those guidelines. Their latest iteration was to 2023. Are you able to confirm that the research that you have undertaken in the past and are undertaking now is being done in accordance with those guidelines? Starting with Dr. G.
Look, I can't, from a personal level, any research that I have been involved with previously has always come under those guidelines. And in fact, research generally in the public hospital is under the guise of the ethics committee. Yep. So there's oversight, and in the private centre that I was actually affiliated with had a private ethics committee as well. Particularly in early years, when looking at stem cell and those type of research projects. And the guidelines are very strict and they're very clear. And I can personally say I've not been involved in anywhere that hasn't been either aware of those guidelines and also actually doing research projects within those guidelines.
I completely agree. I mean, I've got 49 different grants totaling over $70 million and 9 NHMRC grants. And so I'm very well aware of the research and the guidelines, and all the research I've done fully
conforms with
is in line with those guidelines.
No, thank you. Fine, Doctor.
Thank you for the question. In fact, in our submission, we put in a paper that we'd written about the law and oncofertility, and
Oh, great.
yeah, and where it, we saw some gaps. And page 328, actually, of the journal,
right?
We actually specifically talk about the NHMRC ethical guidelines.
So just, I'll write it down. Which journal was it?
So this was the Journal of Law and Ethics, I think.
Oh, Law and Ethics. Yep.
Yeah. JLM.
Yep.
So.
No, that's fine. I'll track it down.
Yeah, sure. And it is an appendix. So in there we talk about the NHMRC ethical guidelines and the issues specifically relating to oncofertility. Storage of gonadal tissue gametes is the best means of preserving fertility. The risks are low. The child or the parent has consented. Collection is for their reproductive need and not that for another individual.
Yes, indeed. Yeah.
I think a bit of a grey area for us will be then the use of that tissue. So I think that I do think that. And that's from really a legal perspective.
So this is a prospective issue, or are we here now?
We're here now.
Okay.
We're here right now. We've got young people that are now adults.
Yes,
and
you mentioned earlier.
Yeah, wanting to know if they can use their tissue. And we're just trying to figure that out through our institutions in terms of how we do that. Is this a novel technology? If it's research, then then it could be difficult, unless the law is changed. And so I think we do need to address that quite urgently, really, quite urgently. I do think with New South Wales it's a little bit more open, but see, it's all down to interpretation. And even the laws, they talk about gametes. And there's gametes, eggs, sperm, ovarian tissue. Testicular tissue doesn't have gametes. It's got germ cells or spermatogonial stem cells. So, there are gaps in the law, and so I do think that we need to address that as soon as possible in the best interest of our patients. The whole ethical premise of doing fertility preservation in the first place is that, for our young patients, we're saying, well, some of these procedures are innovative, but by the time you get older, the research is being done, and we hope the research will advance so that by the time you get to this age, we're able to actually do something about it. And, when we're not able to, that's an issue. And that does conflict with NHMRC. You know what I mean? So we need to fix that law so that we can, pursue what we set out to do.
I guess the other area is that the first thing we shouldn't do is do no harm, okay? So we also need to have the data to identify who should have fertility preservation and who shouldn't. So if you think about precision medicine and the whole genome screening that a lot of the cancer patients are having now, we need to identify which patients are going to have new novel therapies and what the risk is. Because we indeed may be suggesting that some patients should have fertility preservation and they don't need to, or some patients are not having fertility preservation and they do. And that's where I say that data should be very much part of the recommendation, so that we're collecting in a registry the outcomes from who has access, what tissue is collected, what is the quality, but also what is the use. If you have low use of tissue, then as a group of taxpayers will say, well, why did we do that? Why did we collect tissue if they're fertile? Okay? And this also comes down to money. We all should be advocates on how our money is best spent. And the best way to identify that challenge is to know the patient population and the risk based on conventional treatment, that's chemotherapy, radiotherapy, and new therapies. And the last thing is, here we're talking about cancer, but remember, a lot of these new therapies are used outside of cancer. So if you've got inflammatory bowel disease, if you've got vascular malformations, if you've got epilepsy, if you've got renal problems, these are all using small molecules and immunotherapy. And so there is a larger group of patients who are at risk. The gonatotoxicity of their treatment puts them at risk. And so the same management, again, we haven't got a word for this yet. Oncofertility is cancer and fertility, but it needs to be a better word that addresses patients outside oncology that have a risk of impending fertility.
Thanks, very helpful.
We could talk to all three of you all day. This has been
Yes,
really
sorry.
insightful, but we have actually gone about 10 minutes over time, so I better pull it up. But thank you. You're all obviously extraordinarily busy women, and we appreciate you being here and sharing your expertise, particularly, and I think, a new angle for the committee to consider in our work. We might have some supplementary questions that we'll put to you on notice if we do, but
Wonderful.
the committee staff will be in touch. But once again, thank you so much for your time.
Thank you for giving us the opportunity.
Thank you so much.
We're now going to have a short break. We're back at 1:20, I think. Yep. Excellent. Thank you. Welcome back, everybody. Can I thank all of the witnesses who are part of the panel that we have now, just acknowledging that we've got 2 witnesses in the room and 3 online. We've also got one of the committee members who will be joining us online shortly as well, so a bit of a mixed media panel, which is good. I just wanted to start by asking each of the witnesses to state their name, position, title, and swear either an oath or an affirmation. And we might start with the witnesses in the room and then go online. So I'll hand over to... We'll start with you, Doctor.
Thank you. I'm Dr. Veena Jayadev, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you.
I'm Professor David Handelsman from Andrology Department at Concord Hospital, and I solemnly and sincerely and truly declare and affirm that the evidence I'm now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. And we'll move online. We might start with Professor McLaughlin.
Thank you. Yes, I'm Professor Robert McLaughlin. I'm the Medical Director of Healthy Male. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Associate Professor Moss.
Hi, I'm Tim Moss. I'm the Health Content and Research Manager at Healthy Male. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, nothing but the truth.
Thank you. And last but not least, Professor Katz.
Hi, my name is Clinical Associate Professor Darren Katz, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Great, thank you so much. So there is a provision for each of you to give a short opening statement to the committee if you would like to. And again, we might start with witnesses in the room. So Dr. Jayadev, would you like to kick off?
So I'm Dr. Veena Jayadev. I'm an endocrinologist working as an andrologist, so a specialist in male hormonal health and male fertility, working at Concord Repatriation General Hospital. I've recently become the head of department there.
Congratulations. Professor Handelsman?
David Handelsman. I'm also an endocrinologist by training, but an andrologist by career and a researcher in that area as well as in clinical practice. And Veena and I represent the only department of andrology in the country with specialised expertise in male reproductive health, medicine and biology. So we have a distinctive perspective. We've put it in the written submission. Mm-hmm. There are certain programs which we may come back to, but particularly sperm cryostorage as a fertility preserving procedure for men about to have sterilising chemotherapy, and also other forms of treatment for infertility, and also we do some transgender medicine as well.
Thank you. I might now go to the Healthy Male representatives, either or both of you, whoever's comfortable.
I'll commence. Professor Rob McLaughlin speaking, the Medical Director. Healthy Male, for background, is a not-for-profit organisation funded by the Commonwealth Government Department of Health, Disability and Ageing that for the past 26 years has been the source of evidence-based information on male sexual and reproductive health for the government, the profession and community. To achieve this outcome, we collaborate with Australia's foremost clinical and academic experts. Healthy Male is the principal contact for the Commonwealth Government and for Australia's men's and boys' health communities. We had a leading role in the preparation of the National Men's Health Strategy 2020 to 2030. The significant burden of male infertility is a concern to us, noting that in Australia, male factor infertility solely explains about a quarter of the cases and contributes to about half the cases overall, and for most, the cause is not known. And the lack of knowledge about the cause of male infertility really reflects a lack of attention more broadly to the male contribution to fertility and reproduction. Pertinent to this inquiry, I'd like to highlight our work in the Your Fertility website, educating Australians, the development of Australia's first clinical guidelines for the management of male infertility, which are endorsed by all professional societies, the inclusion of male-specific indicators in the ART database, called ANZARD, that captures clinical data from all ART treatment in Australia. and also our work with leading authors in this area of reproductive health, as recently published in the prestigious journal Nature Urology. Now, we continue to address the challenge that male infertility is managed by a range of practitioners, GPs, urologists, endocrinologists like myself, and obstetrician gynecologists. And in some of these disciplines, there's little specific training in male reproductive biology. But most importantly, at the community level, we have a focus on health information, and as our health content editor, Associate Tim Moss, with us today, can speak to those efforts past and future, and the way in which we have utilised new technologies and approaches to spread the word. So in summary, infertility is a condition that affects couples who wish to reproduce, not individuals, and all aspects of support should be given to meeting the needs of both partners.
Thank you. And our Associate Professor Moss, did you want to add anything to that, or you're happy with that as the opening? Good.
I have nothing to add.
Okay. And again, we'll head to Associate Professor Katz for your comments.
Thank you. Look, it's an honour to appear before Slip.
Oh, we've just spoke too soon. We've just lost you, unfortunately.
Dear.
That's okay. We might. What we might do is just start off with the questions, and then when we get our connection back with Associate Professor Katz, we can let him make his comments, I think, if the committee's happy with that. Sure. Mm-hmm. So we have resolved that we'll just do free flow questions between sort of the committee members. I might just ask one and then I'll hand over to some of my colleagues. But all of you make the point in your submissions in various ways about the importance of being conscious of male infertility throughout this as well. Oh, sorry, we've got you back, Associate Professor Katz. Do you want to try again with the comment, with your opening statement?
Sorry.
That's okay.
So I'm not sure where you left off.
We didn't get any of your. It might be a good idea to turn the camera off because the connection is not great. So if we can hear you, that might be better than.
Okay.
If that's all right. Sorry.
How to the camera. I don't know how to turn off this camera on this.
That's okay. It's kind of working now. So why don't we persevere? Yep.
Okay. Good. Okay, so do you want me to start again?
Yes, please.
Okay, so it's an honour to appear before the Select Committee on Fertility, Support and Assisted Reproductive Treatment. My name is Clinical Associate Professor Darren Katz, and I'm a urologist based in Melbourne. Together with a multidisciplinary panel of experts, some of whom join us today, I was privileged to be the lead author of the first ever Australian evidence-based guidelines on male infertility, published in the Medical Journal of Australia last year. I also represented the Urological Society of Australia and New Zealand as leader of a special advisory group of andrology and infertility for 6 years, and therefore I dealt with any male infertility issues across Australia and New Zealand, which was forwarded to the Urological Society for comment. This parliamentary inquiry is a commendable endeavour. However, many of the terms of reference did take a female-centric approach, and like Rod said, it's imperative to appreciate that a male factor contributes to 50% of cases of couples' infertility, and may be the sole cause in close to 30% of the time, and 1 in 3 reproductive cycles actually occurs solely because of a male factor. So therefore, any inquiry that does not meaningfully engage with male fertility will produce an incomplete picture. Turning to the terms of reference F and G, potential barriers and safeguards to reproductive treatment. Whilst I practice in Victoria, I believe that the New South Wales fertility landscape is broadly similar in that the vast majority of fertility care is delivered in the private sector. I'm sure this panel is aware of the fiscal pressures that private hospitals are currently facing, as evidenced by the health scope collapse. The economic viability of non-denominational private healthcare is particularly at risk. And if faith-based institutions continue to acquire some private hospitals and those institutions restrict reproductive services based on religious principles, then patient choice and access to advanced reproductive care, both male and female, may be significantly curtailed. This is particularly concerning for complex male infertility management. In New South Wales, as in Victoria, there are very few specialists that can handle the full breadth of complex medical and surgical infertility cases. And given the complexity of the surgeries involved, those surgeons typically operate from just 1 or 2 private hospitals, So if those facilities are acquired by faith-based institutions and services withdrawn, male fertility care in the state may be severely restricted. So my key message to the New South Wales government is the follows. They should really carefully consider the impact of fertility care provision in any future healthcare institution acquisition. So look, thank you for listening to me, and I look forward to your questions.
Thank you. Thanks very much. So as I said before, we'll just do sort of free flow questions, and I might kick off. And really, it's to all of you. I think, and particularly noting what you've just said then in your remarks, Professor Katz, certainly from the committee's perspective, we are interested in all facets of issues as they relate to infertility and fertility challenges, including male infertility, and we certainly did talk about that in the debate in the House when we set this committee up. So we're very grateful to have you here to provide your perspectives and your professional views today. Pretty broad question, but I guess in terms of the community awareness around male infertility and the impacts that has, and I note that Professor McLaughlin, you talked about some statistics in your remarks. What are some of the things that you think this committee could recommend around raising awareness of issues around male infertility? What better supports need to be put in place for men as part of this journey that we could recommend? And again, happy to hear from all of you, whoever wants to contribute.
Perhaps Tim? Tim?
Look, already there are a volume of information sources available online, certainly from our organisation, from Healthy Male. I think a concerted effort to simply raise awareness that male infertility is such a common contributing factor to infertility problems is important. We say in our recent guidelines that Darren's the chief author of, that the male and female investigations need to run in parallel. We shouldn't be waiting until we've ruled out or ruled in a cause of infertility in the female partner. Male partners should be investigated at the same time.
Mm-hmm. I think Professor Handelsman wanted to comment.
Look, I would like to add to this point that it's not just male infertility such as it is. There's an important preventive aspect which we deal with very substantially. It is that sperm cryo storage, particularly for men about to have potentially sterilising chemotherapy for cancer, 90% of them, 10% are non-cancer diseases. In that situation, you can prevent infertility. We've stored sperm over 4 decades for 4,000 men. And we've been able to achieve pregnancies in 2 examples for over 20 years of storage, where the cancer's cured but sperm doesn't recover. And we've had one which at 26 years, the longest recorded cryo-storage pregnancy in a couple. And so that program is very successful. It's hardly known anywhere. We are aware that younger oncologists and oncology nurses in particular are aware of it, and they channel people to having cryo storage before they have their chemo or radiotherapy. But there are certain things we cannot do. And in particular, we provide cryo storage in Sydney. The specimens have to be fresh to be frozen. And we cannot provide services for rural, regional and remote areas. Patients in those areas with cancers, there's increasing dispersion of the cancer treatments to those areas. They often have treatment conveniently, locally, but they cannot store sperm. They have to come to Sydney to do that. And that's a terrible arrangement. What we would like to see is priority given to sperm transport in the way that's done for organ transplants, because the sperm has to be transported within 24 hours. It's not impossible. It's done for organ transplants. But in these situations of cryo storage, men outside the capital cities are just left bereft. They have no option available. So I think prevention is an important aspect where it's obviously an issue.
Thank you. Did you? Yeah. We'll go, Ms. Carter. Please, sorry, no, please, hang, sorry. Just, did you want to add, sorry, Susan.
Sorry.
Did you want to add something, sorry, online?
Yeah, I was just going to endorse what David said, and also remind the committee this occurs in the paediatric age group as well. It's not just men as in over 18, because there are plenty of boys in mid-puberty and beyond in the paediatric sphere that have the same threats to their fertility, and they also need to be taken into this process of making sure that service delivery is not regionally specific, it's available to all.
And we had some witnesses prior to the lunch break who were specialists in that paediatric sort of oncology fertility space. So that ties in very nicely. I'll just hand over to Ms. Carter.
Okay, thank you all
Mrs.
for
Carter.
being here. My question really is for Professor Handelsman and Dr. Jayadev. Fascinated, in fact, by your submission where you talk about testosterone abuse and links to male infertility. I wonder, I mean, I'm aware of looks maxing, testosterone use to enhance apparently virility. Just wondering if you could tell us a little bit more about that and the risks to male infertility and whether these are actually popularly known.
Look, it's a very good question and something that we've been focused on quite a bit for several years. There's no doubt that androgen abuse, not only just testosterone but other things, other androgens as well, is very common. I've recently got out some statistics. If we look at the prevalence of androgen abuse, there's more people abusing androgens than are those on opiate substitutes for heroin addiction or fentanyl addiction. It's a common problem. It's like anything to do with male reproduction. It's not well recognised. I mean, over a career you realise that the term fertility is code for female reproduction. And in that spirit, anything that involves the men are largely overlooked, but there's a tremendous abuse of androgens in the community. I'm very disappointed in a way that the TGA and the Ministry of Health in New South Wales, both of whom have the mandate to try and prevent some of this, don't do very much. And there are flourishing clinics that are abusive medicine, to put it mildly, where they attract in people, sell them at huge inflated cost, androgens they could get on PBS if they justified it, but they usually don't. And these clinics flourish. Occasionally they're shut down and they re-emerge like a phoenix with a new name down the road. So I think there's important things to be done in New South Wales. TGA is obviously federal, but the Ministry of Health has a pharmaceutical branch which used to, and it still does a little, to try and clamp down on this, but it is a preventable cause of male infertility and other things. We see couples where where the husband has been abusing androgens, wife does not necessarily know, they have no sperm, and he doesn't admit to why that's so, but eventually it becomes evident.
And androgens, where are they obtained? Are they all dispensed by clinics?
Well, they can be prescribed by doctors for a proper purpose, and I think the TGA and drug evaluation committees basically have proper guidelines for that, but they can be purchased over the internet freely and cheaply, and that's even easier in some respects than going to some of these low rent men's health clinics which prescribe them at an inflated cost with contracts, all sorts of financial gimmicks to fleece the people who go there because they're embarrassed.
And have you got any evidence, or should we be concerned about young men in particular being targeted with looks enhancement, social media influences and whatever?
Look, I think that's your question's right on the money. Yeah. It is an issue that gullible people get drawn into this. There's a lot of influencers who try to pretend that you can improve your physique. You can to a degree by using a lot of testosterone or other androgens, but it comes at the cost of suppressing fertility and possibly being very slow to reverse. One of the most disappointing things about this is that abusers think that if they stop, everything goes back to the way it was before. That's just not the case. We've done a study that takes between 6 and 18 months to recover. And in the meantime, when they've been on high doses for some time, their own system is shut down, they stop, and then they're deficient. And they know that if they start up again, they'll feel better. And that's a kind of vicious circle that's encouraged. It's a form of what we call androgen dependence. It's not as well known as opiate dependence or glucocorticoid dependence, but it's very real. So it is a preventable form of not just male infertility, but male hypergonadism or testosterone deficiency as well.
And is it reversible in all cases, or?
That's a very difficult question. In the studies we did, they mostly reverse within up to 18 months, but there's a proportion, maybe 5 to 10%, that do not recover at all. And they are more represented by the professional bodybuilders who have been on high doses for very long periods of time. The time to recovery depends on how long you've been off. And if they've been on for a very long time, there are some I've seen who do not appear to recover even after many years.
And as far as you're aware, is there information in, for example, the bodybuilding community about the fertility impacts of taking these androgens?
Look, what you call the bodybuilding community are mostly drug dealers who are selling their products and have no restraint like we do in any other advertising space about any conflicts of interest. And they encourage all sorts of things. They don't encourage concern about side effects, I can tell you that for sure. They minimise them, they deny them, and it's just not a fair presentation.
Okay, thank you.
Yeah. Dr. Cobb?
Thank you. Thanks so much for being here today, and I was very impressed to read about the highly specialised work happening at Concord. And I suppose I'm asking this question with my GP hat on, with apologies that it's accidentally a bit of a dick. So for Healthy Male, I used your resources when I was studying for my fellowship exams. How do we improve the availability of this kind of information for patients and treatment options within mainstream and non-specialised health services? So, I'm thinking about primary care, regional-based hospitals. What kind of things should we be looking at recommending?
Look,
Amanda.
Yeah, why don't one of the others talk?
We might just start. Sorry if I can. We'll come back to you, Professor, but we might just start online. Yeah.
We know from work from research we have done, surveys of a nationally representative sample of men, that younger men, who we might be more concerned about in this context, primarily get their information about their health from online. So this sort of information needs to be in the online space. Unfortunately, we are outcompeted by those influences that David was just telling you about. That's primarily it. Healthy Male, as you kindly said, provides education for clinicians as well, and we've saturated that market so far as I can see.
Please.
In terms of increasing awareness, decreasing stigma, that was one of the key points of the guidelines that we put out. There are 80 guideline statements, and I'm happy to share those with the committee after the meeting. But some of the key recommendations, and these were guidelines that were made for all practitioners, be they GPs, trainees, specialists who manage infertility, the full spectrum, and there are 80 of them. And like Professor Moss says, some of them are very simple. You should assess the male and the female at the same time. I can't tell you how many patients have turned up to my clinic where the female has gone through a whole gamut of testing until eventually the male just puts up his hand and says, "What about me?" And they said, "Oh, well, yes, we could probably test you as well." And that could be 6 months, a year down the track, and lo and behold, he's infertile, and that's the cause. So promotion of guidelines like this, I think, would go a long way. And yes, there was some good media at the time these were released, and this helped a lot of not only patients, but feedback from GPs and specialists. That's helped them to give them a bit of a framework on how to manage infertility, but certainly just raising awareness that this is a common problem, and also problems that can be treated potentially will go a long way to reducing the stigma amongst males who still feel that this is a hit to their masculinity when they're told that they're infertile. So it's really important, actually.
Did you want to add something to that, Professor?
No, I think I agree with all the comments that have been said before. It's a very difficult thing because you're trying to promote awareness of documents and so on. The ministry probably has an ability to try and promote such things with advertising and targeting to particular specialty areas. But there's no magic bullet, I don't think. That's unfortunately something the medical schools also need to take on. You know, even in my own medical school, they really don't have much content on andrology. So medical students graduate with knowing very little. So that's another area that could be dealt with. In my medical school, I used to give a lecture on androgens, 1 hour or 1.5 hours in one of the 4 years. There was no other teaching about andrology or male infertility or androgen abuse. And as I said, androgen abuse is more common than opiate substitution treatments. So it's a common enough problem in the community.
Yes, please, Doctor.
From a primary care perspective, very few people know that the andrology department in Sydney exists. It's not really on the New South Wales Health website that I saw. I think partly because fertility preservation includes oocyte and sperm cryostorage, and we don't do oocyte, so we sort of missed off. But we do provide about 80%, is it, David, of the state's cryostorage. Furthermore, we've got a few experts there who are more than happy to guide any callers through without having to see the man necessarily. So, but again, it's not out there that we are approachable and available that way.
Also, thank you for sharing. I suspect you'll get some more calls now.
All very happy, but there's also no performance management indicators for it. So within my hospital itself, if I'm giving advice over the phone to colleagues, colleagues who are working rural, remote, that I can often do. We've got very intelligent doctors elsewhere who are very passionate and driven and just need access to someone to run it past, an idea past, or get clarification on same papers they've read or guidelines. There is no performance. I can't bill. I cannot outline it as a consultatory service that I've provided. It's just something done in your own time.
Please.
I might just add one other reflection from history, and that is that we were doing sperm cryostorage for 35 years before one of the people I noticed went out, who was here, Antoinette Anazotto, very cleverly got government funding for fertility preservation, because it was then becoming possible for women only 2 or 3 years ago. And after 35 years of no funding for sperm cryostorage, suddenly it hitched onto the back of that movement. So that's a reflection that there's very little appreciation of male infertility and even very effective prevention, which was ignored for decades.
I might see whether Mr. Donnelly or...
Just perhaps that last answer was interesting about time ago, the issue of treatment of male infertility some time ago, if I understand your answer. Can you explain what past practices were and their efficacy compared to where we are today?
Look, it's a sorry story. Even now, I think, as Rob McLaughlin pointed out, I think there's almost no causes of male infertility well understood. We deal with about 1 or 2% who are gonadotropin deficient, and we use a form of what's a male version of IVF very successfully, and we're the largest centre in this country and one of the largest in the world that has turned that into a success. But it's only 2% of male infertility. The vast majority of the rest have no known explanation. There's not enough research to identify it. I'm sure that many of the causes are genetic and some are environmental, but if there isn't an effort to prioritise research in that area, nothing will turn up. You know, the Australians as a nation have had a very substantial impact in learning about causes of male infertility, but it's not enough that what we've done. We need to be able to do more to get causes for the large number that are unexplained still.
One perspective of this is that the success of IVF techniques, for example, sperm microinjection, which has been over 30 years now, has meant that gynecologists would drive treatments where their only concern was to make sure there were enough sperm to do that procedure, and not to go back to say, well, hang on, why has this guy got such a low sperm count? What can I do? And this is a battle that we fought for decades until about 5 or 10 years ago, we convinced them that it was essential that men be evaluated as part of their process into an IVF program. And so it's now part of the registration requirements that is undertaken. But you'd think it's a pretty obvious battle to win, but it took a while. But I know people are on board now, and certainly the younger generation of specialists understand the responsibility. And one of the reasons we wrote the guidelines is to make sure that those younger folk are really educated and up to date with what they need to know. But I think we're catching up quite quickly. In terms of cause of infertility, David is correct. I think a lot of it will be genetic, and we're basically peeling back layers of that with each passing year, identifying additional new causes. But there needs to be a lot of focus on research, understanding what's going on with the complicated process of sperm production.
Just one final question. Just your thoughts.
Could I just add to that?
Please.
That there's a very interesting historical reflection that there's a desire for a quick fix. And clearly IVF is a quick fix, and it means that there's not as much investigation into the causes. Very similar thing happened in nephrology. When renal transplantation became available, much of the analytical research in causes of renal failure dropped off. It's a larger field, and eventually a lot of it's caught up. But there's the same dynamic at work, and that is a quick fix means that you don't worry about the causes.
Just my last question. You'd be aware that at the Health Ministers' meeting last year in Perth, they issued a communique, and in the communique they had a specific part of the communique which dealt with the reform of the regulatory and accreditation environment for the assisted reproductive technology sector. I'm wondering, that was announced, but obviously not that long ago, but there appeared to be some desire to progress this at a reasonable clip by the health ministers. And it says in the media release, ministers agreed that the Australian Commission on Safety and Quality in Healthcare should provide independent accreditation for ART services against updated national standards. These will include performance monitoring metrics, workforce and staffing guidance, and clearer complaints pathways. Work will commence immediately, and the new accreditation requirements will be in place by January 2027. I'm just wondering, and it's an open question to all participating this afternoon, any preliminary thoughts or comments about the announcement and any particular matters that you think are worth particularly commenting on?
I usually handball to Rob McLaughlin.
That's okay. We do a lot of handballing politics too. So.
Look, I have been an advocate of increased standard of care, clinical competency, structures for review all the way through. And I've been associated with the Fertility Society for decades. And I think there has been a change to recognise the importance of standardising procedures and protocols to improve care, avoid misadventure. And I think everybody is really understanding what needs to be done and are supportive of that. I am not currently involved in those, if you like, high-level negotiations with the fertility industry about such things, but I would believe that people are on the same philosophy that we have to improve standards of care, and that's often best done by having very clear structures, review procedures and educational materials available.
Okay, thank you.
I think Miss Savell, who's online, has a question as well, so I'll just hand to her.
Thanks, Chair. Look, I've just got one question for you all, or whoever you want to handball it to. Just around prevention. It seems, it's something that in healthcare we need to always be mindful of doing more of. What does the research and evidence tell us about, prevention and early intervention and what more we can do in that space?
That's paternal, perhaps.
Yeah, I think that we appreciate now that successful reproduction depends not just on the health of mothers, but also on the health of fathers. So doing what we can to improve the health of men before they and their partner conceive will be of benefit. The ordinary, boring things like diet, exercise, sleep keep people in the best physiological condition, and that helps their reproductive function.
I might venture to answer the question also to say that prevention depends on knowledge of the causes. And unfortunately, the lack of research in the causes of male infertility means that we can give good general health advice, but specific things for particular conditions depend on knowing the causes, and we don't know that in enough detail yet. It could be something in our environment. It could be a common genetic factor, but we do not have enough information yet to give a more than good general health advice.
And on that note, there are, like in one of the guideline statements, and this echoes back to what Professor McLaughlin was saying, was that if there is an abnormality in the semen analysis, traditionally, if there was sperm, IVF, move on. But what we have suggested in our guidelines was that that patient should be further assessed by a specialist in male infertility, because not only might we find some of the causes, and one of the more, over the last sort of 5 or 10 years, has been some causes that have become very important, like something called a varicose veins of the testicle, which can be associated with both primary and secondary infertility, and treating those can make a big difference. But also there are other health-related diseases associated with, that can be associated with and has infertility, and just the abnormal semen analysis may just be, let's say, a canary in the coal mine of what's going on in the person from a greater perspective. So that person needs to be assessed from a more global standpoint. So that's one of the key recommendations of the actual guidelines.
So it's the case at the moment that isn't standard practice, is it? That there isn't that automatic sort of referral on, it's just considered IVF is your sort of only option, no further intervention?
That is correct. I mean, we even know that the sperm can affect everywhere, not just from fertilisation, but all the way to even, into the pregnancy can affect the viability. Recurrent miscarriages can be associated with having a varicose veins. And so the truth is, it is important that if a patient is deemed to have an abnormal semen analysis for whatever reason, that should be assessed at the next level. It shouldn't just be accepted that it's abnormal and move on. That's a really important part of the assessment of the male, and it's one of our key guideline statements.
There are certain conditions which are much more prevalent in men with infertility. For example, androgen deficiency, they can often go together. Also, conditions like testicular cancer is strongly associated with a history of infertility and undersemen testes as a child. So there are issues that go beyond the reproductive system which need to be holistically evaluated. So this sort of sperm jar approach to fertility used to be the case. As I said, I think it's changing. I think that we've certainly put a lot of material out to educate the IVF community doctors and frequently present to them and provide them online training programs. So we're doing the best we can to get everybody on board with this philosophy.
I think it's worth saying that this relates back to a point that Rob made earlier, and that is that fertility services are provided by a disparate group of specialties. There may be obstetricians, gynecologists who have particular training in female reproduction. There are not many fertility services nationally who have Rob McLaughlin and David Handelsman on speed dial to get the andrological expertise that's often needed.
And just a final question, if I might, Chair, just to follow up for Professor Handelsman. Perfect world. When you talk about not knowing enough about the underlying causes, what more research or, what is needed and if we as a committee were to recommend something to for the government or for the federal government to look at in this space, what would that be?
Look, one of the lessons you learn over a career of research is that many of the most important findings are unexpected. And it's very important we shouldn't think that you can ask a question and get a specific answer. It does happen, but it's the small minority. The best thing you can do is to support curiosity-driven, high-quality research. There's plenty of it around. There's At the present, in Australia, less than 10% of ideas grants, which are the main NHMRC funded research into new ideas and research, less than 10% of them are funded, probably only 8%. Now, most of those, probably 30-40% from my experience on the panels, are really worthwhile doing. That would turn up a lot more than trying to say, I want to know the exact cause of this particular condition. There's a place for that, but really it's the untargeted, curiosity-driven, high-quality research which is what we need to make advances. Most of the great advances we've had have been from that background.
I think Ms Hurst has some questions.
Thank you. Oh, sorry, there was...
Can I please just add?
Yeah.
NHMRC's own data shows that about 10% of the amount of grant funding that is given to women's and children's health is given to men's health.
Thank you.
Thank you. And actually, this sort of follows on quite closely with that. And I noticed in the healthy male submission, you talked about the most common reproductive treatments to treat male fertility require healthy women to undergo invasive procedures that risk the woman's own health. And I guess this is a question really for everyone. Is that, again, an outcome of that lack of priority of research? Is there a way out of that going forward if there is more priority put into that research and particularly into that space as well?
Our current lack of understanding as to why sperm production is poor means that we can't make it better. We can't improve it. So the default is to take whatever sperm you can get and use it for IVF, and automatically that puts a burden on the female partner because that's biologically where the action has to be, egg collection and embryo transfer and the like. So it's just a consequence of the fact that if you're going to default to using assisted reproduction because you don't understand the basic issues of the male, you should go back there and understand the basic issues of the male, and maybe things will change.
Historically, IVF was invented to overcome infertility in women who had tubal disease, where you could bypass the blocked tubes and fertilise eggs and put them back in the uterus. Over a very short period of time, it transferred to being a major treatment for male infertility because there was no better knowledge and no better treatments. And the solution to the question you're asking is really to get better knowledge, because then you could go to more specific treatments. You wouldn't have to have the woman investigated completely before you arrive at a male who has a problem. You would investigate the two in parallel, as Darren Katz said, and we would get a better answer, but it requires more knowledge. There's no magic bullet for that. It requires more untargeted research.
And can I also just ask one last question? Professor Handelsman, you talked a little bit before about the capacity to freeze sperm and how it's very difficult for people in regional and remote areas. I'm assuming that a lot of men may not necessarily even know that the service is available. I'm wanting to know, sort of on a more practical level, if that does become a lot more education out there and a lot more access out there, what is the current capacity if you guys are one of the only units that are available, or are we really needing a whole lot more infrastructure in this space?
Look, I can give you a reassuring comment that we are about 80% of the cryo storage in Sydney. There's another smaller group, Prince of Wales, that does some as well. We're fairly busy, but we've worked out if we took all the young male cancers under the age of 45 or 50, we could deal with that. The issue is that many of them occur in a distance, and they'd be forced to come into Sydney for that. Now, if we suddenly had everybody wanting cryo storage, we would need some expansion, but we've got good facilities now. We've had a recent expansion, actually, which the Ministry of Health supported. So the prospect's good. The problem is that we can't deal with people outside the capital city at the moment because there's no priority for fresh sperm getting to Sydney the way that an organ transplant does.
Thank you. Thank you.
Thank you. That actually takes us perfectly to the time that we have with you. So just on behalf of the committee, did you want to add something else? Sorry, Professor?
I wanted to leave one last comment.
Yeah, please.
It was in our submission. We had the experience of going through from beginning to end to sperm donor insemination, And were doing that from before 1980 till we stopped in the mid-1995, where anonymous sperm donation obviously had no social licence anymore, and donors had to become known if they were willing to be a donor. In a way, we've learnt over the long tail of responsibilities from donor insemination. And if any of you ever watch Long Lost Family on the ABC, the tragic stories of adoption with a relinquishing mother at the centre of it are really being replayed through donor insemination, where children, the offspring, aren't given sufficient attention. They want to know their genetic origins. And my concern about surrogacy, it's already available in Australia for altruistic reasons, although there's loopholes driving through that. But if there's a desire, and I get the sense there's a desire to licence commercial surrogacy in Australia, from our experience, it should be absolutely essential that the egg and sperm and gestational carrier should be identifiable to a future offspring. If these are being done overseas, almost certainly that's not going to be the case. Even if it's done in Australia, that should be the requirement. So that was the end of our submission.
Thank you. Appreciate that. And thank you to all of you for your time and sharing your expertise with us. It was certainly very valuable to the committee and will be throughout the course of our deliberations. So thank you. There may be some supplementary questions that committee members have for you after today. And if that's the case, the committee secretariat will be in touch in relation to those. But for now, thank you very much.
Thank you.
Thank you very much. Thank you indeed.
Thank you all.
So the committee will now take another short break and resume with the public hearing at 3:30. Excellent, thank you. Well, welcome back to our final session for today's hearing. I want to thank all of the witnesses for being here today and for your submissions. We're just going to start with asking each of you just to state your name, your position title, and also swear either an oath or an affirmation, and we'll start with you, Ms. Stewart.
Thank you. My name is Claire Stewart. I'm the Advocacy and Engagement Manager at Mito Foundation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms. Mansell.
My name's Julia Mansell, and I'm the CEO of the Human Genetics Society of Australasia, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you.
My name is Kathleen Lamarquand. I am the Chair of the Professional Issues for Genetic Counsellor and a Senior Genetic Counsellor at Royal Prince Alfred Hospital. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Thank you. Hello, my name is Emma Bonza. I'm the CEO of Genetic Alliance Australia. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Fantastic. Thank you so much. There is an opportunity for each of you to make a short opening statement for the committee if you would like. So we might start with you, Ms. Stewart, if you're happy to kick off.
Mito Foundation supports Australians impacted by mitochondrial disease, or MITO, a collection of severe genetic conditions that can cause disability, organ failure and premature death. For many families affected by MITO, assisted reproductive technologies are essential healthcare that can allow families to have children without passing on this devastating disease. Today, I particularly want to highlight the experiences of women with disease-causing mitochondrial DNA changes. These women often face complex reproductive pathways and may require IVF with pre-implantation genetic testing, donor eggs, surrogacy, or in future, mitochondrial donation. Access to these options in New South Wales remains inequitable, particularly for people living in regional areas and people on lower incomes. I want to briefly mention Emily's story, which I have provided to the committee as an additional case study today. Emily lives in regional New South Wales and has spent years trying to navigate reproductive options after learning that she carries mitochondrial DNA changes. Emily was not referred to a New South Wales Health funded IVF provider, despite relying on the disability support pension for her income. She was offered genetic counselling only through private one-off paid appointments that she could not afford. And after years of saving, the costs of IVF and pre-implantation genetic testing still place important reproductive options for Emily out of reach. Emily's story raises important questions about affordability, referral pathways, access to genetic counselling, and regional equity in fertility care. Finally, I want to highlight mitochondrial donation. For some women, this may be the only option to have a genetically related child without MITO. Ensuring New South Wales families are supported to access Australia's pilot program and preparing for future clinical availability is critically important. We welcome the committee's attention to these issues and look forward to your questions.
Thank you. Ms. Mansell?
So I'd like to say thank you to the committee for the opportunity to appear at this hearing about this very important matter. I'd also like to thank Kathleen for making a submission to this inquiry on behalf of the HGSA and the profession of genetic counselling. The Human Genetics Society of Australasia is the peak body representing human genetics workforce in Australia and New Zealand. Our members include clinical geneticists, genetic counsellors, clinical scientists, researchers, educators and policymakers. The HGSA members work with individuals and families who have a genetic condition or a genetic predisposition to developing significant health concerns. These individuals and families have a higher chance, between 25% and 50% chance, of having children with significant health concerns. Therefore, access to assisted reproductive treatments such as IVF and pre-implantation genetic testing provides hope, agency and reproductive options for these people with these genetic health conditions or predispositions. These reproductive technologies are not a luxury or a nice-to-have option for these families. In many ways, they represent the only way that people with genetic health conditions can plan their families and hopefully avoid the very stressful pregnancy experiences such as prenatal diagnosis and possible termination of pregnancy. Unfortunately, treatment and referral pathways are still very challenging in terms of access and cost. The fragmented service delivery models create confusion and delays when navigating between different services within the health system. The human genetics workforce represents an important professional group that can help to support fertility services with greater efficiency. Genetic counsellors are allied health professionals with specialist training in human genetics and counselling. They support people through the emotional impact of genetic health risk, educate them about management options, including assisted reproductive technologies, and provide accurate interpretation of genetic test results. Increasing access to genetic counselling in the fertility services care pathway would help streamline access to services and provide greater support for people considering IVF and PGT. In addition to people who already know their genetic risk, population screening programs focused on genetic testing such as reproductive genetic carrier screening, which is recommended for all people planning a pregnancy, will mean that more people will become aware of their genetic risk and may choose to access assisted reproductive treatments, increasing demand for these already high demand services and increasing the need for genetic counselling in these settings. We appreciate the committee's interest in our submission and the specific needs of people with genetic conditions, including the importance of genetic counselling.
Thank you. Did you want to add anything at this point?
No, that's fine. Thank you.
Thank you.
Ms. Bonser.
Thank you. I'd also like to start by really sincerely thanking you for the opportunity to give evidence today. Genetic Alliance represents people affected by rare genetic and undiagnosed conditions. For the people we represent, the experience of IVF can be really different to a typical infertility journey. Their experiences are often shaped by diagnosis or lived experience of a serious illness. Importantly, many of these individuals are not infertile. They are seeking to make informed reproductive decisions in the context of preventing severe, often life-limiting genetic conditions in their children. So this may include people who have already lost children, people who are caring for affected children, or who live with these conditions themselves. For them, IVF with pre-implantation genetic testing, known as PGTM, may offer the possibility of having a child without passing on the condition. Medicare obviously recognises this by part funding PGTM for conditions with no curative treatment and with significant impact on quality of life. We know as reproductive carrier screening expands, more families are being identified as at risk before pregnancy. But the identification of risk without equitable access to genetic counselling and accessible IVF, including PGT, does not create meaningful reproductive choice. In fact, it can increase anxiety and fear in relation to pregnancy. Time is also really critical because many of these families have actually spent years on a diagnostic odyssey, or they may have shortened fertility windows themselves due to the conditions. IVF with PGTM also frequently requires multiple cycles because in many conditions, up to half of the embryos may be affected and unable to be transferred. In New South Wales, families who reach this point face an additional barrier. If they can afford private care, they can begin IVF with PGT, sometimes within weeks. But if they cannot afford private IVF, they wait, sometimes years, for the one single publicly funded supported pathway of IVF with PGT. And the barriers for those that are in regional and rural areas are heightened. For some, that wait might actually impact their ability to have a child within the window, and others risk conceiving an affected pregnancy before they can access the care that they need. Extending public capacity for IVF with PGTM and better access to genetic counsellors with integrated care pathways would really significantly help these challenges. With the committee's permission, I have tendered today a written testimony prepared for this inquiry by a Sydney resident with a rare condition who has navigated 4 IVF with PGTM cycles within the public system, within the public pathway, incurring over $23,000 in out-of-pocket costs and is at the point of having tested embryos ready for transfer. This is not costs including transfer. This is pre-transfer costs. And she is sitting in the back here, very generously attending today. So thank you so much. I look forward to your questions.
Thank you. And thank you to Lisa, I think it is, who's in the gallery. Thank you for sharing your story through the additional submission. So the committee has resolved that we'll just have sort of free-flowing questions, so it could come from any or all of us. I'm looking if anyone wants to start, otherwise I'll keep... Dr. Conn, I'll let you take the first.
I was just reading that additional submission with the story of Lisa, and thank you so much for putting a human face to the issues that we're talking about. One of the things that you touched on in this submission was the issue of availability of services and timing, and we had a discussion with an unrelated witness earlier this morning about early pregnancy assessment services needing to be open 7 days a week because the issues you're dealing with don't always happen during business hours. This submission also speaks to timing issues, and I was hoping you could explain that in more detail.
Now, I need to explain that, don't I? Because Lisa is not sworn in.
Yeah, unfortunately, yeah.
Well, I can start, and then maybe I'll pass to you. So, when our families are accessing IVF through private pathways, those clinics operate with extended hours. They operate on weekends. It's designed around the window to increase the chances of a woman having successful egg collection and also a successful cycle. But in the public system, the 3 public sites have limited funding, and therefore that constrains the way in which they are able to deliver the services. So maybe it's better for Julia or yourself to talk to that.
I'm quite happy to answer the question about the timing. So families or individuals going through IVF and PGT who have a genetic condition have a window of opportunity because of their genetic condition just as much as the lengthy wait for the workup. These couples having to wait extended periods of time are losing their reproductive window time. So their condition progresses over time. So they don't want to wait 18 months, which is about the average at present, to be able to be seen in a public IVF clinic for PGT, and that there is only one PGT clinic in the public domain at present, and that's putting enormous constraints on that service.
Thank you. That's well explained.
I just want to add one thing which we might need to give you further information on, but there's a technical thing too with PGT that the embryos need to get to day 5, don't they, before they can be tested. And then that process of warming up the embryos, testing them, and then identifying which ones are available, and then the timing and transfer, the embryo transfer is all kind of quite critical. So I think one of the things in Lisa's testimony, and again I've only read it, but the thing is that if that transfer day lands on a weekend and the clinic's not available on the weekend, then that's a lost opportunity.
I can see Lisa nodding in the background. I'm just saying that so the record reflects it, but feel free if you have additional technical detail to provide us, you're welcome to provide that on notice.
Yeah, thank you.
Thank you.
I wanted to go to your submission, Ms. Stewart. I was really interested in the work of your foundation, but it's also, this whole panel around sort of some of the genetic testing and things, but also specifically for the work that your foundation does. I was really interested in your recommendations around mitochondrial donation. I think you mentioned in your opening statement that maybe in the future there's opportunities. I think recommendation 4 talks about the Mito Hope pilot program, which I wasn't familiar with. Can you talk to us a little bit more about what that is, what you hope to see as possible in the future as well?
Yeah, absolutely. In 2022, gosh, it's a long time ago now, Australian Parliament passed under a conscience vote a piece of legislation called Maeve's Law. What that provided for was changing the embryo research law in Australia to allow, under a research program, mitochondrial donation. What that means is that in the lab, and soon moving through to a clinical trial setting, families where the woman has a disease causing mitochondrial DNA change can use a donor egg combined with the nuclear DNA from herself and the father, in most cases, in some very rare cases a donor, to form a baby that is genetically related to her but does not carry that same risk of mitochondrial disease. It's been Australia's the second country in the world to legislate specifically for this technology, and under an MRFF grant of $15 million, Monash University is being funded to run this pilot program in a research setting. So it's called the Mito Hope program.
Okay, and that is starting soon, did you say? Or
yeah, so the program was funded approximately 3 years ago.
Okay.
We're not yet ready to open the clinical trial.
Yep.
Mito Foundation is a partner organisation in that program. The work that's been done to date has been largely navigating the new regulatory process using the National Health and Medical Research Council's Embryo Research Licensing Committee. Their remit was expanded to include the responsibility of issuing licences for mitochondrial donation. So it's a very carefully regulated process, and the team has been navigating that over the last few years. Recently, they secured the first licence for mitochondrial donation in the lab. So over the last few months, they have been performing mitochondrial donation in a training and research setting in the lab on human cells, which is an Australian first. And that gets us closer to being able to open the clinical trial so that families who advocated for this legislative change, for whom this is the only option for them to have a child genetically related to them with a reduced risk of disease, can start to access the program. We're hopeful that that will open later this year.
And you said another jurisdiction, Australia was second.
Sorry,
I think.
yeah,
So
the United Kingdom passed legislation about 4 or 5 years before us.
Okay.
And late last year published the outcomes of their program, including the number of healthy babies born.
Okay, and so it's been successful.
Yeah,
overseas.
it has resulted in babies born with a far reduced risk of contracting disease, but babies take a while to progress, and so they'll continue to be monitored. But the signs are really positive. And it is a very complicated thing. It's very cutting edge technology in some ways, but it is the only option, and Australia's on a journey to that. From a New South Wales point of view, I think the future is the question of when it comes out of a clinical research setting and into clinical practice. I am not a legal professional, but my understanding is that for it to come out of the clinical research setting would require New South Wales or potentially other states and territories to change their laws for embryo research or embryo work on embryos.
And from another practical perspective, we already have multiple patients sitting on a wait list in the hope that they will join that from New South Wales.
I wondered just, I guess, a more broad question too, in terms of some of the, this is a good example of like advancements in technology helping women and families, but I guess also in your experience, and I'm assuming that a few of you have worked in this space for a little while, like an increase in the number of patients who are sort of discovering some of these genetic issues, but also looking for support and help. Lots of nodding, again for Hansard, but I guess just in terms of your own professional experiences or through the organisations that you work with, how much more demand is there for things like the pre-implantation genetic testing? I'm assuming it's increasing, and what are some of the factors around why you think that's the case as well? And I'm happy for all of you to answer.
Well, I guess the best evidence that we have so far is from a large pilot project that was done called Mackenzie's Mission, which was a large reproductive genetic carrier screening project where they screened, 10,000 couples and identified that 2% of couples, so 1 in 50, are what we would call high-risk couples. That means that they have a genetic condition where there's at least a 1 in 4 chance that as a couple they would have a child with that condition, affected child with that condition. And one of the things about that program was about also trialling to determine the number of people who then, if they were found to be high risk and then offered PGT, would they take it up? So we actually did some stats around that. So we were looking at about 2% of people in New South Wales, means that if you think about 88,000 babies born a year, that's maybe 1,700 couples a year, or around 1,700 couples. And we understand that around 70 to 80% of people would want, or couples would want, the PGT. So as the reproductive genetic carrier screening is rolled out more, more fully, more comprehensively, we expect that there'll be more people identified and therefore they'll want to avail themselves of the technology.
And that is only in the area of recessive genetic conditions and X-linked genetic conditions. When we think of the broader context of genetics, when we go to mitochondrial but also dominant genetic conditions, which are where most of these parents are affected themselves, either the father or the mother, the increase in getting clinical diagnosis or a genetic diagnosis, these patients has just exponentially increased. So they're all now very fully aware of their diagnosis, and having a genetic diagnosis is the power to be able to use PGT. Prior, they had a clinical diagnosis and they had to take that risk having a child. They knew it was 50% risk, and they would do that knowingly. But now with a genetic diagnosis, they can have the other options, which is really important for them.
Did you want to add something, Ms. Ponce?
Oh, I was just going to say, and potentially because we are seeing more and more conditions added to newborn screening, and we are seeing research in genomic newborn screening, the first children who had delayed diagnoses and affected the reproductive decision-making windows of people having subsequent children, that will close as well, and that I think also will increase demand for access to these services, but also really importantly the wraparound care and support. And to your question around an increase an increased need, we have definitely seen more prenatal cases coming through Genetic Alliance to the point where we now employ a community-embedded genetic counsellor part-time in our charity to try and help people advocate along the pathways to accessing these options.
Yeah, that's interesting. I'm just wondering if any of my colleagues have got questions of this. Yes, Miss Hurst. We do also have one of our members online. I should have said that earlier, but we'll go with Miss Hurst.
Okay, thank you, Chair, and thank you all for coming today, and thank you for the work that you do in this space. I have a question for Julia and Kathleen. I note in your submission that you said it can take 3 to 4 years to see a clinical geneticist on the public wait list. Which is obviously something that's then required. I'm wondering if you can give a bit more information as to why those wait lists are so long, and what recommendations we can be making as part of this report to overcome such extensive wait times.
Okay, sure. Those wait lists will vary from one health district to another, and just as a snapshot, just so you are aware of what they really are, for instance, Westmead Adult Hospital at the moment, it's a 4-year wait list to see a geneticist, whereas to see a genetic counsellor, that wait list is around 3 months. Liverpool Hospital has a 2 to 3 year wait list to see a geneticist, where a 5-month wait list for a genetic counsellor. RPA, where I work, it's a 1-year wait list for a geneticist, 4 months for a genetic counsellor. If you go out to Western New South Wales into the regional, the regional centres, we're looking at 2 to 3 years for a geneticist and 2 to 3 months for a genetic counsellor. So you can get the disparity between those wait lists. When you need a geneticist, it is a very long wait. Why is there such a wait in the western districts, which is far more than the inner city, is because the population is much bigger in those districts, and they are of a more reproductive age. There's younger families out in those districts, and there is a very big need for genetics with the explosion of those populations. There's a higher level of consanguinity in the southern southwestern area. How can we address those? I think definitely more resources. That's easy fix, but that's money, which is, we all know, is not coming forth quite so easily. So resources and more trained professionals in genetics, so education of other professionals as well in the genetic space. I don't know what you'd like to add, anything, Julia?
I'll probably just, as you were speaking, just thinking, does everyone understand the difference between a clinical geneticist and a genetic counsellor?
A follow-up question. Please enlighten us.
So I think that is part of the bottleneck, I suppose. So a clinical geneticist is a medical physician, usually someone who's already trained in a specialty, a medical specialty. So often paediatricians or an adult physician, and we're getting people from other medical specialties as well, who then has subspecialised again to do advanced training in clinical genetics. So there's someone who's done a huge amount of training, and their job is primarily to diagnose people with genetic conditions, and diagnosis of genetic conditions can be challenging because they're often multi-systemic. So where you have specialists who work in cardiology, they're only looking at hearts, or renal, specialists, they're only looking at kidneys. Clinical geneticists are looking at whole body systems and making a diagnosis. So whereas a genetic counsellor is an allied health professional, usually with some science-based training in their undergraduate, and then masters trained in genetic counselling as a specific profession. And there are more of us. There are currently 430 of us working, I'm saying us because I'm a genetic counsellor too, working in clinical practice in Australia, or on the HGSA register of genetic counsellors. But we think that there are probably about 750 who have been trained, and so therefore there's 300 effectively genetic counsellors who are trained as specialists, allied health specialists, but don't have jobs in the field. And part of that is because the majority of genetic counselling positions are funded through public health services, which is state government funding, and we don't have a funding source to provide services outside of public hospitals. So that's a challenge, and that's something HGSA has been advocating for.
And am I right thinking that the counselling doesn't get Medicare subsidies as well?
That's correct.
And so if we had Medicare subsidies, would that be part of the solution to ensure that more people could access the counsellors and take some of the pressure off these long wait lists for
It could be part of the solution. I guess what we, from HGSA's point of view, we've been advocating to try and find a model of care that allows for genetic counsellors to work outside of the public hospital system. So public hospitals should be for people who are unwell or need acute care services, and some of these other services could be provided, like some of the psychosocial support, some of the navigation support could be provided in community settings if we had other funding structures or funding envelopes. And yes, MBS or Medicare is an obvious one, and we did put forward a pre-budget submission a couple of years ago for that, but haven't been successful so far. So we continue to work in that space.
Thank you.
Let me add one lived experience point around what Julia's talking to. One of the really strong observations in the IVF genetic counsellors we speak to, and in the families that come through GAA, is the level of misinformation about what is actually available to them in terms of IVF pathways and the testing that they have available to them in that sort of primary care and sort of mainstream setting. And it's very difficult to access a genetic counsellor in those settings. But actually that is where the impact on families actually starts. And that is why I think it's so important when we think about access to genetic counselling. It's across different parts of the system to address where people are actually addressing, like, coming to terms with a diagnosis or are making decisions that often sit outside or not strictly within clinical genetic services.
I wanted to say one more thing, I'm
please.
sorry,
No,
but I
no,
just wanted
please.
to say one more thing, which is that for our pre-budget submission we had some cost-benefit analysis done which demonstrated that for every $1 spent on Medicare for genetic counselling there was a $2.50 return on investment. So it's proven to be cost-effective.
Yeah, fantastic. Thank you. And I also just wanted to ask as well about regional and rural access, particularly because I note that your submission also said that the only public clinic offering IVF with pre-implantation genetic testing was the Royal Hospital for Women.
Correct.
What does that mean for people living in rural and remote? And I know that some of the submissions also talked about the lack of and the barriers to telehealth as well, and how that can kind of all work together.
I think I'll just say quickly because I wrote that part in the submission, is that the regional people find it very difficult because to come to those services they would have to attend in person. the genetic counselling side of their journey can, of course, be done on telehealth, and we provide those services as much as possible, where possible. But when it comes to the actual PGT side and the more medical side, they can do some of that in satellite centres and work with the Women's Hospital, but they are on the wait list like everybody else. So it's one service for all, which is very difficult. So they're fighting an even bigger battle, and maybe Claire has something to add there. So.
Yeah, I'd refer you to Emily's story. The reason that we put that together with Emily is because I think it illustrates that regional access challenge. I don't think it's a simple case of they have to travel a little bit further. What we hear from families living in regional areas affected by mitochondrial disease is that they're often not referred. So their clinicians almost act as gatekeepers, or in some cases their clinicians are just not aware of services. A GP is really well trained and really well equipped with knowing about local services. But if they live in a place where those services are not available, then who is helping that family navigate to those services? So it's not just about, well, I have to go and move, take myself off to Randwick Clinic. But if no one's told me about Randwick Clinic because they're not aware of it, then there's a barrier there that is far more than the distance or the expense of travelling. As someone who lives in a regional area myself, I know from the people that I talk to, where I live in Orange, that people are just not aware of some of these specialist services and that gap to actually accessing the care that they need and having full access to those options. What I've seen happen in Emily's story is that her GP just referred her to a low-cost provider. So there's a number of low-cost providers, not state-funded, I should say maybe medium-cost providers. So they're not the services that actually can provide PGT in the private system, because they're very high-cost providers, and I think Emily's GP believed that she couldn't afford that, which I think is fairly true. So instead she was referred to a service that was inappropriate for her. So it wasn't the lower cost provider that might have been able to help her in the public system. It was a sort of medium cost provider that didn't know about these technologies and doesn't offer them. Unfortunately, that provider didn't refer her on to a more appropriate service. So Emily is now saving up for a service that actually possibly is not the right fit for her. So a combination, I think, of living regionally and also not being appropriately referred to a really well-equipped genetic counselling service to identify the options.
And I just want to make one comment around some of the things that are often kind of highlighted to alleviate concerns, for example, like the IPDIS travel arrangements. So what we have heard from our regional families is that it doesn't fully address the needs of that repeated metropolitan attendance, multiple monitoring of appointments, accommodation burden, time away from work, childcare pressures, even like cumulative travel fatigue, because IVF with PGTM requires frozen cycles. It's actually splitting the time. It's increasing the amount of time they need to spend in the city. So it's amazing that we have it, but actually it doesn't really acknowledge the burden of these processes. And the additional thing to raise here as well is that for many of these families who are coming to this process because they have a child identified and they have additional financial pressure as a result of not being able to work, having to care. There's many well documented financial burden evidence around people who have severe heritable conditions in their families. So it's the cumulative impact that regional families really feel, as well as the absence of information and awareness of options.
Thank you. Thanks, Chair.
Thank you, Mr. Donnelly.
Thank you. And through you, Chair, thank you for coming along. It's great to be able to see you and ask you some questions personally. And thank you for the submissions. They're very, very helpful. My question, I think I'll direct it to Ms. Lee McQuan, but there may be the others who want to chip in, so I'll let you make.
We're a team.
No, so we'll start, but please chip in. In terms of the education and the training of genetic counsellors, I'm wondering if you could provide an explanation about how that's done, where that's done, what institutions provide it, what the cost is, etc., etc. So it's quite an open-ended question.
Okay, so genetic counselling is, we are trained in the University of Melbourne or UTS at present, so there's only 2 places within Australia.
Right.
It's a postgraduate master's, and it's a 2-year master's, and both courses are very similar and are coordinated likewise.
Can I ask whether can it be done remotely, so someone over in the West could do it remotely? Or
yes.
West Australia?
Yeah, so the Melbourne course is very much an in-person course, the Melbourne
Right.
University course. The UTS course is remote, and however, you do have to attend certain clinics and times and things like that. And you've got to do your clinic blocks, but they can be arranged in different places.
So it's a 2-year equivalent full-time course.
2-year full-time masters.
Masters, yeah.
One of the biggest issues for the UTS course is there are no Commonwealth assisted places. It costs in excess of $85,000 to do the masters. And unfortunately, as a new grad genetic counsellor, you'd be lucky to make $80,000 in the public health system. So that's one of the difficulties, whereas Melbourne University has some Commonwealth assisted places. However, it's still an expensive course.
So with respect to the graduate, does the 2 years masters, completes it, graduates, they receive a credential, which is Masters of Genetic Counselling.
Correct.
What is the typical, and I know it can vary between people, what would be the typical, use the term, career path or path that an individual would follow upon graduation and progressing their future?
Well, there's a lot of variance these days because the genetic counselling can work in either a clinical setting within a public health setting. That would be getting a job within the public health setting and starting at the base level under the Allied Health Award.
Right.
Or they go into the private health setting, into an IVF type company, an ultrasound company, just a private genetic service. They're more limited because genetic counsellors do not have a Medicare rebate for seeing patients. It's very costly, so it's not that successful. For genetic counsellors in the research setting, they may go into universities, into research laboratories. There's also people in policy, people in education, so it is quite varied. So there is no typical, really. They'll go and get a job wherever they can get a job. There are very few jobs at the moment. We're putting through 60 to 70 new grads per year, and there are no new jobs.
Or the combined too?
Combined.
Right.
Combined. And there are no new jobs in the public health system. So
in Australia?
In Australia.
Wow.
So it is very difficult. The competition is high at the moment. It has been cyclic over the years. Of course, these things go up, they go down. But at the moment, we're putting a lot more graduates out there because the workforce study by Ministry of Health in New South Wales saw the shortfall and said, right, we need to address this. The future is genetic counselling. We need genetic counsellors in the system. We need to educate more. So we did. And we are. And so we've got this excess at this point in time. So now we've got the need, we've got the genetic counsellors, now we need the funding to put them into the appropriate places within the health system.
And beyond that career path you've described of entering into the public sector or the private sector or research, what would happen next for, once again, forgive me using the typical average genetically trained counsellor? Would they aspire to progress to doing other things beyond working for a period of time in those 3 areas?
Possibly.
Yeah.
I mean, we've all taken different pathways. I think Julia is a good example here where she's gone into, I'll let her tell her what she's done. For myself, I've worked very much in clinical space and I've taken on different specialties, particularly in the prenatal space. I've worked overseas. I've worked with a lot of culturally diverse people, so I've worked in that space and worked my way up to be in a managerial role in the public health system. So you can climb, but we've hit a bit of a ceiling because I'm sort of my level and one above. That's it for genetic counsellors at the moment. We've got a bit of a ceiling. Allied Health is going through a lot of changes as the award's changing at the moment, as you're probably aware. So we're trying to get a better career pathway. But there are different pathways, and people will take different pathways in research and in corporate. So Julia's done that a little bit more.
Thank you.
My story is a little unusual, but yeah, I started working in the lab, then became a genetic counsellor, and then I've also worked in federal government, in Department of Health, in policy type jobs, and now I'm working as been in and out of the clinical role. I still work 1 day a week as a genetic counsellor, and then I am in this job as the chief executive of the HGSA for 4 days a week. So, yeah, I guess people take a lot of different, as Kathleen says, different pathways, different roles.
Can I add one thing to that?
Yeah.
I think Ms. Bonza, mentioned earlier that Genetic Alliance does have a genetic counsellor embedded as a service provider as part of that, and that's NGO funded. We have also seen, I've observed, for example, in the USA, that many genetic counsellors are actually very effective in some of the rare and genetic disease non-government organisations as well. They bring a really wonderful skill set in counselling and understanding genetics and genomics into those organisations, and I think there's huge potential for that to grow in Australia as a part of that maturing sector of organisations like Mito Foundation and Genetic Alliance as well.
We spend a lot of time working with support groups. So.
At the moment, vast majority of the time, entirely voluntary.
But I think it is about the funding, the access to funding is the challenge. Yeah, so I think there's, a lot more workforce potential because people have been trained, but there's just not the positions. And we know, you and I would both know people who have at least 5 years experience as genetic counsellors, and their short-term contracts have ended and they can't get another job.
Right.
So we've got some real problems.
Oh, that's very helpful. Thank you.
You're welcome.
I have another one, but I don't want to take time off others. Yeah, thank you. To you, Ms. Bonza, I was interested in the part in your submission where you talked about the coroner's project and some of the post-mortem. It's a little outside what we've been discussing so far in the committee, but just sort of interested to understand that a little bit more. And presumably, I think the sort of intention is, if things can be carried out even after tragically a child passes away, trying to sort of understand any kind of genetic predispositions. Could you just talk to us a little bit more about that?
Yeah, definitely. And I'm also happy to provide more detailed information about the coroner's project on notice.
Yep, that would be fine.
But the reason we included it is because essentially it's advocating for that more routine consideration of genomic testing in coronial inquiries, which are really typically really expensive processes, really prolonged processes. Those processes have significant psychological impact on families, and often without routine access to genomic testing, a finding may not, a cause of death may not even be ruled. And again, when we're talking about infants and young children, we're talking about women who are in a reproductive decision-making window. And Kathleen will be able to talk to some of the sort of system barriers around this, but ultimately what the coroner's project is trying to educate around is that for a lower cost versus a standard investigation, there's the ability to provide people with more information that may inform and reduce the risk of losing another child to a genetic condition. So for some families, a genetic cause is only identifiable after death. The information is critical to surviving family members, not just in making informed reproductive decisions, but also to other family members, relatives that may carry the same variant. And I included it in the submission because some of the families that are seeking access to IVF with PGTM, they only learn about a genetic condition after a devastating loss. And I think this is something that, I'd love for Kathleen to talk a little bit about what is already in scope but not utilised versus what, more information we can provide you about the coroner's project.
Yeah. Did you want to add something to that?
I guess I'm not sure where you're going with this, Em,
Sorry.
but no, that's fine. I think with genetic testing, I think one of the biggest points that we're trying to make for any of this is to have for families to have the opportunity for testing.
Yeah.
Whether it's through a child that's died or through a child that's got a condition that's undiagnosed, or just what is the cause is so important to these families. And it's not the individual. So I think this is the biggest difference with most areas of medicine and genetics. Genetic is not just geneticists, genetic counsellors. We don't only work with an individual, we work with a family. And so that puts us apart from all other health professionals. So our focus, it might be to get a result on an individual, but the meaning of that result is important for every single person in that family. And so our work works across the family situation. So it is a little bit different, and it's why it's very time heavy and emotional for all of the families involved. But these projects are so important.
Could I just
Please.
provide a
Yeah.
little information about the Coroner's Project, because one of the two amazing mothers that's driving this advocacy, her name is Danielle, and she had 2 children and she's lost them both to sudden cardiac arrest. They had a genetic condition called PPA2, which is actually a form of mitochondrial disease, so we work closely with Danielle on other topics. Sonny was Danielle's first child, and he died without any notice. Essentially was unwell, and that triggered a metabolic crisis in his body that led to his heart failing. They only found out about Sonny's potential diagnosis after they had their daughter, Airlie. That allowed them to more actively manage Airlie's health, and that prolonged her life, but she still died at the age of 2.
Yeah.
And that's an absolute... I'm struggling to tell that story without tearing
Yeah.
up, even though I've heard it many times.
Yeah.
The opportunity that Danielle is trying to help people understand,
Yeah.
that she's written to the Attorneys General and the health ministers of each state, including New South Wales, is that we have an opportunity here. By looking and being more progressive in our use of genomic testing earlier in coronial investigations, we can identify diagnoses for babies like Sonny and help families like Danielle's choose to access options if they'd like to, like PGT, but also prenatal testing and active identification of either having a child with a reduced risk or managing that more proactively in that person's lifetime, depending on the condition and the family's values. And unfortunately, I got an update from Danielle about a month ago after we got this invitation. And unfortunately, I've read the letters back from the Attorneys General, and they seem to say we're just going to continue as usual. And I think it does need some more attention, because this is where some of the potential of using these technologies we're not able to realise.
That's really useful for the committee to know that as well, and I think that's the point of trying to hear from a lot of different people who work in the many complexities in this space, to try to be as expansive as possible as we can be as a committee in terms of the recommendations that we ultimately make. So thank you. That does, I think, bring us now to the end of our time with you, but thank you so much for your submissions, but also being here today. I think there might have been 1 or 2 things taken on notice, and we may also have some supplementary questions that we want to put to you. So in that case, the committee secretariat staff will be in touch with you just about that process and how it works. But thank you all for being here today, and also for Lisa in the gallery for being here and sharing your story in writing for us. It's important, and that will be now lodged as part of the committee's deliberations as well, and also for Emily sharing her story through Year Claire as well. So thank you for that. So that concludes today's hearing. Thank you very much, and
Thank you.
Thank you
appreciate your
so
time.
much. Thanks for having us.
Yeah.
Thank you.